And we also achieved recognition among oncologists in various fields, which was shown by the wider indications observed in the second survey. We also achieved a standardization of medical care among clinics, which was shown by the introduction of cost with AI for breast cancer and cost with a random stat cost for hematologic malignancy. And as I mentioned, the national subsidy was launched in last year, and it is also accompanied by the launch of registration system, JOFR, and it means that the patient is mandatory to register to covered by its national subsidy. And we are now aimed to improve the quality of fertility. It includes identified effectiveness and short and long-term safety for patients and their children using JOFR registration system. And we're also now working on improving oncofertility network between oncologists and RAI, because as I mentioned, the oncofertility is not centralized in our country. It is based on the network in each prefecture. But the quality of the network is still very different from prefecture to prefecture. So we are now aiming to improve its quality. And now we are also working on the update of this guideline, and which will hopefully achieved by 2024. And also, it is the issue to be addressed for establishing a system securing a long-term storage, because the oncofertility is not centralized in our country. And in the last few minutes, I will discuss about the fertility preservation for benign diseases in our country. As I mentioned, the national subsidy was launched last year, and it covers not only cancer patients, but also some benign diseases, including the diseases requires bone marrow transplantation like Fanconi anemia and thalassemia, and the diseases require alkylating agents such as SLA or DM. But the fertility preservation for these benign indications is still very limited in our country. In 2020, we conducted a survey on the status of fertility preservation for systemic autoimmune diseases at the certified educational facilities of the Japanese Society of Rheumatology. In that survey, almost 40% of respondents reported that they never explained that option for fertility preservation. And furthermore, 1/3 of respondents experienced the patients, most of them were women as expected, who did not receive the treatment recommended by rheumatologists because of concerns about fertility. So more effort is needed to get rheumatologists included in the fertility preservation. And that these benign diseases like gynecological diseases like recurrent mature cystic teratoma or endometrioma, or genetic diseases like Turner syndrome are not covered by the national subsidy today. And we know that whether we do cryopreservation for benign indication or how far, I mean that which kind of patients should be indicated or not should be indicated, it depends on the discussion in the social acceptance. So we have to start discussion in the society. I have many collaborators in this study. I especially appreciate Professor Yutaka Osuga, the chair of a university, and Professor Nao Suzuki, the president of the JSFP. Thank you very much for your kind attention.
Thank you, Dr. Harada. Any questions or comment?
Thank you very much. That's very interesting. Just a couple of small points. What measures did you take to raise awareness of the public of your service? Because the difficulty we have in my area in Manchester, UK, is raising awareness of the parents, particularly because we have a larger group from children, etc., or teenagers. So what measure did you take in Japan to promote this? And the other small question is, what is the largest cohort on term of age who are using your services?
Okay, thank you very much for your question. And for the first one, actually, we use mass media like TV or like some influencer to prevail the conception of oncofertility in the society. It has taken almost 2 to 3 years to prevail that notion of oncofertility, but I think many people, many average people in the society is quite interested in, easy to understand this kind of notion. So I think that the prevailing this notion is quite quick in our society. Yes, it's the first one. For the second one, that as I told in the talk, the leading indication is the breast cancer patients, and also that the age of the motherhood, for conception is getting older and older in our country, so that the most popular age for oncofertility in our country is around mid-30 for breast cancer patients, and this is the dominant age group in our country. Thank you.
Okay, I have just a comment, please, here.
Yes.
Regarding hematological malignancy,
Yes.
I think it is wise to fertility preservation measures. But we have noticed some cases, in spite of doing measures to save fertility, without, but spontaneous pregnancy happen, and no effect of the new chemotherapeutic agents with the babies. So from the area of coverage of, you say that your country do financial cover is safe some resources, and just to comment to you if this cases.
I'm sorry. Please repeat again.
In spite of doing fertility preservation measures, some patients, in spite of giving chemotherapy and radiotherapy for Hodgkin, spontaneous pregnancies, without any effect on the babies. If you follow up with them, they are really good, smart.
Sorry, I cannot understand your question. Sorry.
In some cases of Hodgkin disease, after receiving the chemotherapy or the radiotherapy, there is not any effect on the...
So spontaneous pregnancy, yes. Yes, some cases, yeah, of course. So that explains the very low percentage of utilization of cryopreserved materials like oocytes or embryos in future. Yeah, I think.
What I mean, the new chemotherapy has no effect. Does it have effect on the gonad? We can share documents.
So, thank you. The chemotherapy will not have effect on ovarian tissue because it's primordial follicles. They resist very well to all what you give. They die or they survive. And if they survive, they are well, and the babies will all be very well. All the babies born after ovarian tissue transplantation, they are all after chemo usually, otherwise you don't need to cryopreserve. There is no problem. But It's not the case for oocytes if you are within 6 months after the chemo. You need to wait 6 months after chemo before stimulating the ovaries and having mature oocytes, because this is the last stages. But the primordial, no problem.
Thank you.
Thank you very much. So we go on to the next speaker, who is Professor Mary Madeleine Dolman from Belgium. Professor is head of the Gynecology Research Laboratory at the University Catholic de Louvain in Brussels since 2012, and chef de clinic at the Clinics Universitaires Saint-Loup, Brussels, Belgium. And the topic is on fertility preservation in endometriosis. Thank you.
Okay, so while waiting, I will present 4 options to preserve fertility in endometriotic patients, and I will start with a little introduction on the effect of endometrioma on the oocyte quality and the ovarian reserve. The system is a bit slow today. I don't have videos, you know. So it's my pleasure to present you today fertility preservation in women with endometriosis. It doesn't work. Okay. There. So in 2019, it was still a challenge to preserve fertility in endometriosis. And when you see this, we understand why. As you see this MRI presenting an endometrioma, and the little white dots all around are the follicles. So we can easily imagine that the ovarian reserve is squeezed physically to the edge, and so it is important for these patients to discuss fertility preservation. So the 2 preliminary comments, the ovarian reserve and the quality of the oocyte. About the ovarian reserve, in women with endometrioma, we know that their ovarian reserve is already depleted before surgery. After, we will see the effect of the surgery, but before surgery, already, you see in the big blue line, this is the mean of the ovarian reserve. Well, the endometriotic patients are down at the stage of the blue arrow. So that's their starting point. Indeed, this was confirmed by a big meta-analysis by Muzzi, and he concluded that AMH is reduced in the presence of ovarian endometriomas, even if you compare to patients with other cysts. So it's not the presence of the cyst and the physical characteristics, it's really the presence of the endometrioma. Because if you compare with other benign cysts and to patients with healthy ovaries, their AMH is reduced. And so the endometrioma itself is a cause of reduced ovarian reserve in women with endometriosis. This was a study by Michio Kitajima, who came to my lab from 2011, and in 2014 in fertility sterility, he analyzed why it was already depleted. And so he analyzed the follicular recruitment and the atresia. And to do so, you see here, he analyzed atretic follicles. In red, you have, it was unilateral endometrioma. So a little ovarian biopsy at the site of the ovarian endometrioma is in red, and a little biopsy at the healthy site is in green. And you see that we had 55% of atretic follicles at the site of the endometrioma compared to, it's 20%, sorry. 20% of atretic follicles compared to 6% in the healthy endometrioma. So there is really something inside the ovary that happens when there is that endometriotic cyst. And also, the oocyte itself might be affected. So there are many reviews in the literature, especially from the team of Paola Vigano. And I took this picture where the wonder is the oocyte quality affected by endometriosis. And we see that there are several mechanisms One of these was mitochondrial content and spindle anomalies. Also, they could see zona pellucida hardening. Of course, it's not a conclusion yet, and other studies are needed to confirm this. So for the plan of my talk, how to preserve fertility in these women, well, the first step will be to prevent the loss of fertility. And so this means adequate surgery. I will not pass into review all the studies that are published about the effect, the negative effect of the surgery on the ovarian reserve. So Muzzi again, in several articles, could conclude that close to the ovarian hilus, well, when you analyze the wall, the endometrioma wall by anatomopathology, well, in 69% of cases, you find follicles in what the surgeon thought was the wall of the endometrioma. And you understand why when you see this. So you have the chocolate fluid at the left there in the B figure. Then you have some endometrial epithelium because it's an endometrioma. And then you have the so-called capsule, which is only fibrosis. So there is not always a relative clean cleavage plane. And that is why the follicles that are just next to it are often taken away with the endometrioma wall during the surgery. So what we propose is the combined technique for the cystectomy of endometriomas, which means you start with the excision that you see in number 1, the red arrows. And when you arrive close to the ovarian hilus, where there it is at risk to take away, in 69% of cases, follicles, you stop, you cut the tissue, and you do vaporization with the laser. So in picture, you recognize here an ovary with an endometrioma inside. You cut it open, and you clearly see here the cortex and the cyst. That's easy. You perform the cystectomy, and now you see there, close to the hilus, is the tricky part. You take your scissors, take away the cyst, and then you can vaporize here the rest of the endometrioma wall that is close to the hilus. And this is the end of the surgery there down. With that technique, the ovarian volume and the antral follicular count 6 months after surgery is comparable, so no significant difference between the 31 patients who had surgery with the combined technique compared to a control group who did not have endometriosis. And also, you allow in 1 out of 2 patients, 50% at 9 months after surgery, to be pregnant without IVF, spontaneous. Of course, when we have very large endometriomas, like here, this is an endometrioma of 7-8 centimeters, then you cannot do this technique, the combined technique. You need to have a 2-step procedure because it is too big and it will have a negative effect on the ovarian reserve. So then we advise first the drainage, being by ultrasound, transhysteroscopic laparoscopy or laparoscopy. 3 months generate agonist or antagonist nowadays, and then second laparoscopy for the internal wall ablation. Okay, that is for the adequate surgery. Another option in case of severe endometriosis could be fresh ovarian tissue transplantation. This could be the case in some rare cases where one side, here the right side, has an atrophic ovary, okay, and then you see at the left side a kind of frozen pelvis with the ovary, the tube, everything inside. So the option could be, if you need to do an oophorectomy because the surgery happens to be like that, well, don't send the whole ovary to anatomopathology. If you find healthy cortex, you can take it and graft it to the other side. So in that example, we had some ovarian tissue that was quite healthy looking, and it could be put in a graft area on the other side, which was still healthy. And a few months later, when she had another laparoscopy, we could take a little biopsy of this grafted fresh tissue, and the biopsy is green, so all the follicles that you see there were viable. And of course, third option, cryopreservation of embryos or oocyte, and this was already described. This is the cartoon of the New England Journal 2017. We have the indication of malignant disease, but for sure, benign disease, it is a good option to freeze oocytes. And indeed, severe ovarian endometriosis or recurrent ovarian cyst is a good indication. So we have seen that article from Anna Kobo during the main session today, and I insist on 35 years of age, which is a key moment for the ovary, because when we have younger patients, well, you see in blue, the chances to be pregnant, the cumulative live birth rate is double than when you are more than 36. So with 10 oocytes at the left at less than 35 years, you have 60% of cumulative live birth rate, but with 10 oocytes, if you are more than 36, you have only 30% of live birth rate. So that's an important data. And the same, Kobo et al., they analyzed elective fertility preservation in blue. They analyzed fertility preservation for endometriotic patients in red. And in green, we have the onco-fertility preservation. And so what we see is that it works, of course, also in endometriotic patients, that that threshold of 35 is really important. And the last option I will discuss today is the ovarian tissue cryopreservation for patients with endometriosis. So I will end with a case report. This is a patient who had in 2001 a laparotomy for peritonitis. It was not in our institute. They had to do partial colon resection and they were bilateral endometrioma. She came back a bit later to that hospital and these endometriomas were infected. It was during the night with a surgeon, gastrointestinal surgeon. He came with that frozen pelvis and he performed, she was 21 years of age, a bilateral annexectomy because of these 10 centimeters bilateral cyst. Luckily, during the night, he thought at freezing the cortex he just took away. So that was one positive point of his surgery. And so the patient came back in 2009 to ask us to use that frozen tissue. And so, as you can see, she had no tubes and no ovaries left after her peritonitis and surgery. And these frozen toad fragments were grafted to that patient. For sure, as she did not have any tubes left, she had to undergo IVF. And so one day she came with that image at the ultrasound. So she was given Gonal-F and GnRH antagonist. And she was pregnant in July 2011. She also had a second pregnancy through IVF, but this was the first live birth after reimplantation of frozen toad ovarian tissue in a woman with bilateral oophorectomy. So as at the beginning it was said, well, if the patient, the cancer patient, still has her ovaries, we never know if she's pregnant from the graft or from the remaining ovary. Like you said, it's always possible to have a spontaneous ovulation. But this was the very good proof that without remaining ovaries, well, the technique of transplantation was working. And I will conclude with an algorithm that was published last year in Best Practice in Obstetrics and Gynecology about fertility preservation. And so this is for the case of ovarian endometriosis. What we propose if it is a unilateral endometrioma, and if the ovarian reserve is fine, normal, well, then you can wait for sure. But if the ovarian reserve is low, in that case, you can already propose fertility preservation. On the other hand, when you see at the right side of the slide, in case of bilateral endometrioma, and we have seen it this morning with a nice talk also, in case of recurrent endometrioma after surgery, in case of one endometrioma growing fast or at a very young age, because they will be at risk of recurrence if it starts already when she's very young, well, in these four situations, we propose fertility preservation to these patients, being it either by oocyte vitrification or maybe by ovarian tissue cryopreservation if she needs to undergo surgery for her endometrioma, because you are just there. So in conclusion, we have seen how to preserve fertility in these endometriotic patients. So first, adequate surgery, of course, when surgery is indicated. Fresh ovarian tissue is only in some specific and rare conditions. Cryopreservation of oocytes according to the algorithm, as we have just seen, and cryopreservation of the ovarian tissue, the same according to the algorithm. And so I have 2 seconds to present you the workshop we are doing on ovarian tissue cryopreservation and transplantation in Brussels in January. I thank you for your attention.
Thank you, Professor Mary, for this presentation. Any questions or comments? Okay, Mr. Cook, Dr. Cook.
Hi, thank you for presentation for this hot topic. Now, the message for the age was very clear. I think it's important to freeze when the patient is still young. But this is the message. But about AMH, the dilemma always, when we talk about fertility preservation in endometriosis is when to offer the fertility preservation. I think before the surgery, we all agree if we are going for surgery, okay? But you said in your algorithm when AMH is low, you have to freeze eggs, which may be not the best situation to freeze the eggs. We have the chances in endometriosis to do many cycles, I know. It's not like oncofertility, but do you think that we should better freeze when AMH is still normal, better than when it's low?
Yes, of course. And the other delicate point is, what is the threshold of normal AMH? That is also very difficult. But yes, when it's still normal, okay, but it doesn't come, the slides. But in that case, when AMH is still normal, was for patients with unilateral endometrioma. But as you say, AMH is a global ovarian reserve, so I have some colleagues and I tell them, well, you are measuring AMH to your patient every 6 months. What are you waiting for? That it becomes too low and that it's too late to freeze? So, indeed.
Actually, if I comment on your comment, I think one of the problems in endometriosis is the late diagnosis. Usually when you diagnose, means that there is 7 or 8 years there is an endometrioma. But my question is that, why are always thinking about surgical treatment? Where is the place for the medical treatment? I think medical treatment can protect some of the oocytes. If we diagnose somewhat early, we can start with medical treatment, and as long as the endometrioma is small and is not increasing in size, we can continue for medical treatment till marriage. And
sure,
we can give some
certainly
chance for spontaneous pregnancy.
So if less than 4 centimeters, the endometrioma, we will not jump onto the patient to perform the surgery. And this is one of the slides in the introduction, that surgery is harmful for the ovarian reserve. And we have seen that there are a lot of papers published on the diminished ovarian reserve after surgery. So you're right.
Always I think about medical treatment first, as the first option. Yes, sir.
Thank you very much for the presentation. I'm not an expert in fertility preservation. Just wanted to ask you, you mentioned increased follicular atresia in cases of endometriosis. Is that only for ovarian endometriomas or also endometriosis, for instance, in peritoneum? And
that's a good question.
And what would be the mechanism of that?
Okay, so this was only the case for ovarian endometrioma. So really there was a physical damage of the ovary, and it was only from the side of the endometrioma. So it's, sorry? And the mechanism, we don't know. Well, I have one slide about, if it's still there. Yes, here. It's speculation. It's by the team of, can I have the slides, please? by Vigano, and it is well known that the blood inside releases iron. Yes, the slide will come probably. Releases iron with ROS, reactive oxygen species, which are very toxic for the cells surrounding. And so these go, well, yes, iron, ROS, and this is a toxic content of the endometrioma. So, but it's not easy in vivo to analyze. These are speculative. But indeed, the fact that is why Muzzi saw the difference between endometriomas with this toxic content compared to dermoid cyst.
Okay, thank you very much. Now we move to our next speaker. It is our honor to have Professor Sabratman Arul Kumaran with us from UK. He's Emeritus Professor of Obstetrics and Gynecology at St. George University of London, Professor and the Head of OBGYN SUGL from 2001 to 2013, Foundation Professor of OBGYN University of Nicosia from 2014, and he is President of FIGO from 2012 to 2015. He will address us today about fertility preservation in severe cases of PPH, postpartum hemorrhage. I think this is a very important topic for a country like Egypt, because PPH is still the main killer of our ladies and the leading cause of maternal mortality here in Egypt. So it is a very important topic.
Thank you very much for the kind introduction. I'm going to move from gynecology to obstetrics because I think, again, it's an important area, and there are new methods which are being developed to preserve from doing a hysterectomy so that she can be fertile subsequently. So, of course, she has got pregnant. That's why she has a baby, and then the bleeding. Now, maternal mortality is 30% of maternal mortality globally is due to postpartum hemorrhage, which we think is about 75 to 80,000 mothers lose their lives. But really about millions have postpartum hemorrhage and morbidity, either short-term or long-term morbidity. Short-term can affect the heart, the kidneys, and so forth. And the long-term, it is well known that cerebrovascular accidents can happen when they are later on in life, if they have blood transfusions and so forth. So it's not a simple thing to look only at mortality, but we must look at morbidity as well. Now, in terms of fertility preservation, we'll start with the issue about when do we do a hysterectomy. Well, normally we do a hysterectomy when it is the last thing we can manage to do, because if she had lost a lot of blood, started coagulopathy, the presentation is there, but it's not coming out, so we have to preserve this now. Okay, I'll keep on talking, it doesn't matter. So, first of all, we have to say when the woman loses about 30 to 40% of her blood volume, she develops coagulopathy. And there are two indicators to look at. One is actually the pre-delivery hemoglobin, and secondly, the body weight of the woman, because body weight in kilogram multiplied by 100 gives the blood volume. So if she's a 50 kilogram woman, by 2 liters she would have developed coagulopathy, and it's difficult to do conservative methods, and we have to depend on a hysterectomy to do that, especially in a place where there's no blood transfusion facilities available. And one of the reasons things go on to hysterectomy is because the prophylactic oxytocin we give is not heat stable. So the ergometrine, the oxytocin infusion we give doesn't work in many countries because 30 to 40% get disintegrated. So now there is availability of heat stable oxytocin which can be given, called carbetocin, so which is long acting. It's act for 2 hours, when it is given intramuscularly and intravenously, it acts for 1 hour. So that's the current recommendation by the WHO, to use a long-acting, heat-stable carbetocin. And the temperature-wise, it can stand up to 2 years at 30 degrees centigrade. And even if it is at 40 degrees, it can stand up to 6 months. So that is carbetocin, so that it can prevent the woman from bleeding. Now, if she continues to bleed and develops a massive postpartum hemorrhage, like 1.5 liters, it's too little to manage, so we have to get on with important things. And one of the drugs which are come into use is the use of tranexamic acid, 1 gram intravenously, and it can be given intramuscularly. If you can't get an intravenous route, you can give half on one thigh and half on the other thigh, and the absorption rate is equally good given intramuscularly. With 1 gram, it doesn't stop. You can give another half an hour later, you can give another 1 gram of tranexamic acid. And the earlier you give, the better it is. It is active up to first 3 hours from the time of postpartum hemorrhage. If you give it after 3 hours, the effectiveness is gone, because the clot formation and the clot is not very good, so it doesn't really clot so well. So you have to give it within 3 hours, but if you give it as soon as you recognize the postpartum hemorrhage, then with 70% survival rate. So it's quite important to recognize that we have to give it as early as possible. Now, in the past, we have a habit, when we have massive postpartum hemorrhage, we start an oxytocin infusion, rub the uterus. If it doesn't work, we go into ergometrine. If it doesn't work, we go prostaglandin. If it doesn't work, we give tranexamic acid. So the current consensus opinion of the WHO now is to really give everything together, which is called the emotive care bundle: early detection of postpartum hemorrhage, massage of the uterus, additional oxytocin, tranexamic acid, IV fluids, and examination under anesthesia, so emotive. So a current study which I'm looking at is 140,000 women in cluster randomized trials in sub-Saharan Africa, to see whether emotive will be better than going on a stepwise fashion. Right, so it's coming here, so hopefully it'll come there. So that is the current recommendation on medical therapy. Now, if the medical therapy fails, okay, so I can just go through very quickly. I have mentioned many of these things already. So I have no conflicts of interest other than giving some lectures organized by some pharmaceuticals, acknowledgements to some of my co-workers, and the objectives is to look at new studies on prevention and new medical treatment and surgical treatment, and finally some messages to take home. And that is the mention about 75,000 women die, but annually 15 million have postpartum hemorrhage. So there are quite a number of women will lose their uterus on hysterectomy because simple methods are not available or medical treatment is not applied. Now, I mentioned that when they lose blood, you have to prevent so that you don't go to the hysterectomy, but if they lose further, you have to have treatment before it gets to a rescue stage. And if you get into the rescue stage, it is because the pre-delivery hemoglobin is very low, and patient's blood volume is low because the body weight is low. So before she goes into coagulopathy, you have to do something. Estimation of blood loss is important. 2 parameters, not only visual estimation, but also using an early warning chart, so that if the pulse rate goes to 110, 120, then you know there's a problem. And we use a simple measure of rule of 30, increase the pulse rate by 30, systolic blood pressure drop by 30, etc. Then she's going to go into coagulopathy. I mentioned about the heat-stable carbetocin, which is to be given, and that is very useful. And there are a lot of meta-analysis being done, and the Cochrane Review publishes that if you give oxytocin only, 10% will lose more than 500, but if you carbetocin or combination drug, then only 7%. So it is natural. If you take a heat-stable carbetocin, it's better than the oxytocins into ergometrine combination, because oxytocin is not heat-stable. Then the tranexamic acid I mentioned, large studies has been done. It was initially discovered by this couple in Japan, and she really did the research in order to use for PPH. It was used for a long time. It prevents the clot from getting dissolved or lysis. So that's the principle behind. And that is a woman trial. As you could see, the first line, the deaths due to bleeding is reduced by 30%, but you have to give it within 3 hours. And this is whether it is vaginal delivery or C-section, whether it is uterine atony or tear, it is effective against everything because we give it for trauma as well. And in terms of thromboembolic events, it has been studied in arterial and venous side, and as you could see, there is no difference between the placebo and the tranexamic acid side. So it's a safe drug. It doesn't promote clotting, but it prevents the clot from getting lysed. And there was another study called the CRASH-2 study, again in accident victims. By the roadside, if you give the tranexamic acid and transfer to the hospital, as opposed to taking the patient to the hospital and giving tranexamic acid. In that study, again, 20,000, like the woman study, 20,000. Again, reduction in mortality by 30%. So it is very clear, it saves lives. And here it is to show the line where if you give it early, the chance of survival is about 70%, and after every 15 minutes you delay, there's a loss of life which increases by 10%. And the WHO has come with a recommendation, and it also reduces, not only saves lives, but reduces the laparotomy by 35%. And interestingly, in this particular study, it didn't reduce hysterectomy because they jumped on to hysterectomy early, because many of the centers where the studies were done, there are no blood transfusion facilities. So this is the latest from the WHO technical consultation group, which we said we will do a care bundle approach, and EMOTIV stands for early detection, massage, oxytocin, tranexamic acid, IV fluid, examination, all done at the same time, so that there is no delay in waiting one, whether it's going to act, and the next one. But the most important thing from another study called the CHAMPION is a lot of people don't recognize the amount of blood loss. So you have to start the treatment as early as possible. So this is the CHAMPION study, which showed only 26% of women received additional oxytocin after losing 500 ml. And 30% did not give oxytocin even after losing a liter. So that's quite, this is measured blood loss using measured drapes. Now, if it doesn't work, the simple thing is while you get ready to do a bimanual compression, because it prevents and promotes clotting in the uterine vessels. And you can, if that fails, you can use these balloon catheters. If it is in a poor country like South Africa, they use a glove. In Bangladesh, they use the condom, but there are ready-made available like Buckley's balloon and so on, which can be used. Now, there are newer methods which are coming available. This was the first paper on suction, sucking and collapse in the uterus. And he used a metal catheter, Samatharam, and he used 600 to 700 millimeters mercury pressure to collapse the uterus and stop the bleeding. Now, subsequently, we did a study in Indonesia looking at the standard suction tube folded into a loop and the outer holes covered with a cervical balloon, and created the suction and stopped the bleeding. And that also helps. So you can use a hand pump or a mechanical suction pump. And the same study was repeated in the US with 107 participants. And generally, within 3 minutes, 65% of the women stopped bleeding. Another 4 to 5 minutes for another 15%. So nearly 80-90% stopped within a short time. And questioning evaluation of the use of instructions, whether it was clear, easy to insert, everything was quite simple. So they did the study in the States and they found it successful. So that is the JADA device, or the suction device I showed you just now. So others have started improvising, like Hofmeyr in South Africa. He used a Levin suction tube, which is a gastric tube with a number of holes. And because in periphery in the South African continent they don't get electrical suction, he used a handheld suction, which is used for termination of pregnancy. So with that he was able to achieve hemostasis collapsing. So that can be used. Now there are other new methods coming up. This is a X-stat sponge. That is a sponge which is compressed into small pieces. They put a net into the uterus with a thread to retrieve it, and you keep on putting sponges there, which when it bleeds, it absorbs the blood and expands in size and compresses the uterus. So you can put in as much as it will take and leave it for 2 to 4 hours, and you give some prophylactic antibiotics, and once it is done you can take it out. And to put the sponges, they are a small funnel-like tube which goes through the cervix into the sac, and retrieval is very easy. You just pull it out and it will come out. Now Silex gauze is again shown in postpartum hemorrhage. Silex is taken from crustaceans like the sea prawns, crabs, that crustacean type of shell, which was used in the army where they powdered it, and when they put it in blood, it clots very easily. So when there is a massive wound, they put a tourniquet on the leg and put this and put a bandage, and it stops the bleeding. So it stops the arterial bleeding, and then you can separate it out. So it comes in 3 meter length and 7.5 centimeter, and you can put it into the uterus, tied with one to the other, and put 2 or 3, and it promotes clotting within the cavity, and it stops the bleeding. So these are simple things. You can keep it outside and use it when there is a massive postpartum hemorrhage. And Buckley's balloon, you would have familiar. They use the Buckley balloon, putting 50 to 100 ml saline, and then through the terminal holes they created a suction. So you have something like a technique which compresses from inside and also collapses the uterus at the same time. And the suction cannula on the left side by Panika is similar to the one I showed you on the very first slide. Now, Professor Piley from Kerala has produced some clamps which he can put on the cervical, and he has published a big series which seems to be very effective. And Kerala, where the mortality is very low, they use this as a first approach. And of course, if the clamps and the balloons doesn't work, you have to open and do a laparotomy. And B. Lynch was the first one who showed simple suturing technique can be useful, but it looks a bit complicated. You have to cut open the uterus, you have to go from one end, go around, and so on. So we modified the suture and published this, which is very simple vertical suture. So you don't have to open the uterus. You put a needle in the lower segment, tight on the top, again on the other side, and you can compress and you can stop the bleeding. If it doesn't stop with 2, you can put additional 2 vertical sutures because the blood will drain through that. And we have also used a sandwich technique where you put a balloon, and then first you put the suture and then inflate the balloon. So in placenta previa and so on, it is quite useful to think about the sandwich technique. Now coming to the placenta accreta, which is a major problem. How do we preserve the uterus in placenta accreta? Now you can see from the lower diagram, the blue and the red line around the placenta accreta comes through the scar, so it doesn't really go into a unscarred uterus. Usually there should be a scar tissue, it eats into the tissue and comes out. And so there's a way of trying to cut off and take the placenta out without doing a hysterectomy. So we devised a triple P procedure. Chandraharan did most of the cases, and the triple P stands for placental occlusion balloon. So we get the radiologist to help with the internal cardiac balloon or a uterine artery balloon. Then we do an ultrasound to see where the placenta's upper edge is, cut through the placental upper edge, take the baby and cut the placenta right 3 centimeters above the reflection of the bladder, and take the placenta as a whole. There might be some placental tissue left behind, you can take it, and if there's bleeding, you can put some perclot and you can seal it. So this is how it looked like cutting, and there's a fibroid incidentally on one of the lips. It looks a big hole, but you can close it very easily, and the white substance is perclot, which promotes the clotting. There might be some chorionic tissue left behind, but that atrophies with time, so there's no problem. So you reconstruct, and we have done ultrasound and looked at the menstrual pattern of these women after the operations are done, and few of them have got pregnant. Most of them don't want to get pregnant because they got scared that things might happen again. So this is a series of 50 which we published, and this is the average blood loss, 2.3 liters. And the more we did, less blood loss it was. There was 1 ureteric injury, and there was no hysterectomy in this series. So it is possible to reserve, and there are a number of others who have published on this procedure called the triple P procedure. So the take-home message is first thing is to prevent and start treatment as early as possible. Like cancer, you prevent, or early treatment helps a lot, and not to wait for rescue treatment. And prevention is by heat-stable, long-acting carbetocin, and if she bleeds, then please add the tranexamic acid. And early treatment, you can give prostaglandin, tranexamic acid, and suction tamponade or uterine artery clamp. So you don't have to do a laparotomy, you can do it very easily in your own setting. And you can think about suction, the balloon tamponade with condom or whatever it is, but the newer method seems to be more successful because it seems to be more effective. And triple P procedure for placenta accreta spectrum disorder can preserve the uterus, and they can get fertile. Thank you very much indeed.
Thank you, Professor Kumaran, for this review of the different methods for managing postpartum hemorrhage. Actually, I worked many years with Genuity Health Projects, if you heard about them, and we published the paper in 2010 in Lancet about the use of the sublingual misoprostol for treatment of postpartum hemorrhage. And I think misoprostol is a very, very important drug, especially in our community, in the developing countries. It's quite cheap, can be kept in the room temperature, can be used easily for sublingually without any IV lines. So I think we should give more chances for the misoprostol, especially in our area. I know in the Western countries there is other methods, and especially here we have a lot of home delivery. Still we have a lot of cases delivered at the home and in the primary health facilities. So misoprostol is a very good option.
Yeah.
And the condom balloon, condom balloon catheter also is a very effective method, and is quite cheap.
Yeah, 800 microgram misoprostol sublingually is the best treatment. So it's the FIGO guidelines recommend that, as well as the college. Yeah.
Any questions or any comments? Thank you very much.
Thank you.
Thank you very much. The next speaker, Professor Ioannis Messinas, Professor of Obstetrics and Gynecology at the University of Thessaly, Larissa, Greece. Since 1995, currently Emeritus Professor and Past Director of the University and Honorary Fellow of the Royal College of Obstetrics and Gynecology. Professor Messinas will present obesity and infertility.
Thank you, Mr. Chairman. This is different from fertility preservation. I will try to provide an overview shortly, certainly, about obesity and infertility. Obesity is a very important condition. It's a pandemic, I would say. So it may affect fertility. I have no conflicts of interest for this particular talk. According to WHO, obesity is defined as a BMI that exceeds or is equal to 30, and there are different classes, of course, according to the severity of the condition. And this is the outline of my talk. Very briefly, I will discuss about the impact of obesity on fertility, and also the role in ART, the importance of the reducing weight for fertility, and about male obesity. It has been demonstrated there is an association between BMI and ovulatory disorders. As you can see in this study, for instance, from USA, it was shown that when the BMI is under the normal, or if there is BMI that is increased, particularly in the range of obesity, there is a significant increase in the odds for ovulatory infertility. And also menstrual irregularities may occur, but some women may have normal menstrual cycles, and you can see in this study from USA again, from New York, that with high BMI women who have regular menstrual cycles have reduced excretion of this hormone that is pregnenolone, which is a metabolite of progesterone in urine that is significantly reduced as compared to women with normal weight. And this may be related to disturbances in LH pulsatility, which are markedly reduced. Possible mechanisms include hyperinsulinemia that stimulates increased production of androgens, increased conversion of androgens to estrogen, decreased SHBG production, disturbed pulsatility of LH, altered follicular environment, oxidative stress, lipotoxicity, activation of pro-inflammatory pathways, and changes in the production of various adipokines. There are some adipokines that are important. There are many adipokines. These are the three most important ones. Adiponectin, for example, is decreased in obesity, and that reduces insulin sensitivity. And also resistin is increased, but that increases insulin resistance. And leptin is also increased, but there is leptin resistance. And these hormones have been studied in vitro. We have done some studies showing the impact they have on the production of the steroids. For example, leptin, we have shown that in human luteinized granulosa cells in vitro, reduce significantly in high amounts the production of estradiol and progesterone. On the other hand, we have demonstrated that resistin is also a suppressive hormone that reduces the progesterone particularly, but also estradiol, again in vitro, while adiponectin is considered a good adipokine that stimulates the production of estradiol and progesterone, but in obesity it is reduced, the secretion of adiponectin. Even adolescent obesity is important, particularly in relation to the lifetime nulliparity. As you can see, when the BMI increases, there's a high school BMI and becomes 30 and above, there is an increased probability of the lifetime nulliparity or nulligravidity. The role of obesity in ART, it has been demonstrated for many years now that, particularly from the studies of Bart Fauser, that in ovulation induction there is a reduced response to clomiphene, for example, if the BMI is high. Also, it has been demonstrated that the amount of gonadotrophins that are used, FSH, for example, for ovulation induction in anovulatory women is again increased if the BMI is increased. And also the ovulation rate that is achieved is reduced in similar programs. Regarding IVF, it has been shown that there is a negative correlation between the number of retrieved oocytes and the BMI. And also this depends on the age of the women, which is expected, of course. Regarding the number of developed embryos, as you can see again, when the BMI is under normal, or if it is above normal, and in obese women, there is again a significant decrease in the number of developed embryos. Now, in terms of the live birth rate, it has been demonstrated, this study from France, that shows that there is a significant decrease in the live birth rate. You can see that the confidence interval here does not cross the unity line. So, in fact, as compared to non-obese women, there is a significant decrease in the live birth rate. Now, the reasons for these adverse outcomes are not clear. The group of Carlos Simon from Spain, from Valencia, have tried to explain it, and they have concluded that there is a negative effect on endometrial receptivity through delaying of the window of implantation. They used the endometrial receptivity analysis, their own ERA test, that is known as ERA test. So the endometrium is probably affected. However, this study from USA has demonstrated that in oocyte donor recipients, there is no difference in the clinical pregnancy rate between obese and normal weight women, suggesting that probably is not the endometrium that is affected. And this has been recently confirmed in this retrospective study from USA that again shows in oocyte donor recipients that there is no impact of BMI on the endometrial receptivity. So this does not affect on its own, which means that probably is the disturbance of the oocyte quality rather than the endometrium, but this is a matter of debate, of course. If we look at this data from the UK, you can see that the miscarriage rate is also increasing with the increase in the BMI. And recently in this review from Spain, again from Valencia, it was concluded that higher miscarriage rates are seen after euploid embryo transfer, which means that it is a matter of disturbance in euploidy or maybe increased aneuploidy, but also the embryo morphology is not affected. Similar blastocyst formation, so it is possibly a disturbance in the environment of the uterus. So, in generally speaking, and based on this information, there seems to be debate on whether the poorer outcomes that occur in obese women in terms of fertility and infertility treatment are related to poor oocyte quality or disturbed oocyte quality or embryo development or to disturbed uterine environment. But the possibility looks more likely that it is a combination of the three conditions. And it is obvious that more studies are needed, particularly randomized controlled trials. Now, if obesity affects fertility, then by reducing the weight, one would expect improvement in the treatment. Nevertheless, there are some studies. This is a well-known life study, as it's called. Lifestyle study is from Netherlands, where you can see women with a BMI of 29 and above were divided in two groups. The intervention group that involved 6 months lifestyle changes plus 18 months infertility treatment, and the control 24 months infertility treatment. There was no significant difference in the vaginal birth between the two groups within 24 months, but there was significantly increased live birth rate in the control group, not the intervention, which means that the lifestyle does not have any beneficial effect. And further analysis, this is subgroup analysis of the same study, from the same study, that is another publication. The only significant benefit that occurred here was, in fact, that there was an increase in the natural conceptions only in non-ovulatory women with infertility. And further analysis, again from the same study, showed that in a 6-month lifestyle intervention before IVF improved neither embryo utilization rate nor cumulative live birth rate. So there are, in fact, data that show again that this may be related to an impact of this, an inability of the lifestyle to have any beneficial effect. Nevertheless, this is a meta-analysis from Aberdeen by the group of Bhattacharya that showed that there is, or there may be, increased pregnancy rate. You can see here that this is significant. The statistical evaluation, the meta-analysis, but not the live birth rate. There is, however, large heterogeneity, as you can see, which is related to this study here, which is the lifestyle study that I showed you before, which, however, included the highest number of patients in this meta-analysis. So, as you can see, the quality is low, and of course more studies are needed. There was a mixture of population from different studies that were included in this meta-analysis. However, the same group did a further meta-analysis. This was only this author included in the previous study as well, Damian Best from Aberdeen, and they concluded that women randomized to a combined diet and exercise intervention were more likely to become pregnant and to achieve a live birth rate as compared to women in control groups who received or minimal intervention or nothing at all. So it is in fact a matter of debate whether the impact of obesity is on the endometrium or it is on the oocyte. Regarding the use of drugs that reduce the weight, for instance, Orlistat, this is a randomized controlled trial from China that showed there were two groups here, Orlistat, one group, equal number of patients and placebo, no differences in the live birth rate, and this was independent of various characteristics that were also taken into account. And regarding the bariatric surgery, data are very few in the literature. This is a proposed protocol for a systematic review that was published, and of course we would expect the results of this to see whether in fact there is any new data regarding the bariatric surgery. Now, what about the male obesity? and infertility. There has been an association between BMI and semen quality. In this study from China, it was shown that when the BMI was reduced or it was high, there was again a reduction in the semen volume, semen concentration, total sperm number, and total motile sperm count. And this probably was related, according to this study from China, to increased sperm apoptosis and sperm DNA damage, fragmentation, therefore. However, the male BMI cannot predict the probability of live birth. As you can see here, the live birth rate is similar regardless of the mode of treatment, IVF, ICSI, or a combination, and regardless of the weight of the patient, normal, over, or obesity. In our lab, we have combined the BMI with age, we have multiplied, and we calculated this score here, which, if it is between 700 and 800, it seems that this is the highest pregnancy rate that we achieved, and below that or above that, there is a reduced pregnancy rate, and this is consistent with the decreasing or increasing BMI. Nevertheless, there are no data in the literature regarding the reduction of body weight in men and the impact on the outcome of any infertility treatment. This is a case series from France. There is only data, in fact, in the literature. Very few cases. You can see 8 men who complied here to diet, and 8 pregnancies occurred in their wives, while 7 who did not comply, only 1 pregnancy occurred. This is just an indication and nothing else, of course. And also there was a decrease in the carboxylated proteins that are related to the oxidative stress. However, this decrease was not significant due to the small number of cases. So more studies are needed to see the impact of reduction of the weight in men on the outcome. There is one study, very recent one, this is from Denmark, that has investigated the sperm count that was increased following diet or exercise, which was maintained with exercise, or glucagon peptide 1. But of course, data are few at the moment. So in conclusion, ladies and gentlemen, obesity has a negative impact on the fertility potential. The obese women, even from adolescence, may have menstrual irregularities and lower possibility to conceive. There is reduced response to ovulation-inducing agents, either clomiphene or FSH, and reduced live birth rate in anovulatory patients, of course. Oocyte quality is probably affected. This needs to be further investigated. Endometrial function may be also impaired, and again, more studies should be done on that. Lifestyle modification, however, is recommended, but it only increases natural conceptions in anovulatory infertile women, and the role of men's obesity needs further investigation. Thank you very much for your attention.
Thank you very much, Professor, for your presentation. Anyone, any questions? Okay.
Thank you, Mr., for this nice presentation. As you mentioned, after bariatric surgery, and women decide to have IVF cycle, to do IVF cycle, the drug of administration, subcutaneous drugs, the absorption.
Can you come here? I cannot hear you very well. That's very noisy.
As you mentioned in bariatric surgery. As you mentioned in bariatric surgery.
Yes.
And women decide to do IVF cycle. The drug of administration of subcutaneous drugs, it is good or not?
Well, the data regarding bariatric surgery, as I said, are very few. But if somebody had bariatric surgery, it is recommended at least 18 months without any treatment. And then you can try. But I cannot answer the question whether, in fact, that will have an impact on the pregnancy or not, because there are no data on that.
Any other questions?
Thank you, Professor Messinis. What about you just in one slide you mentioned the role of medical treatment, like Saxenda and these drugs. I think this is very important because surgery is surgery. And if you have a medical treatment, it's much better. What about using this medication in the PCO adolescents?
Well, yes, in PCOS, I don't think it has been used. This is one of the very few studies that I mentioned about orlistat. And in fact, although the weight was reduced, there was no impact on the treatment outcome, and this was IVF. So live birth rate was not affected. Now, in terms of the PCOS, we recommend lifestyle changes and exercise. There are no studies with the use of these drugs, or at least maybe very few data on that, but not recommended as a treatment for PCOS. So at the moment it is the lifestyle changes for 6 months before any treatment. But if the patients do not comply with this, because that is usually what happens, then we have to proceed with medical treatment, and this will not be orlistat, will be in ovulation induction treatment, clomiphene or letrozole, for instance. So that it is good if you, of course, start with a low BMI or normal BMI than to start with a high BMI. And this is also for the consequences that may occur during the pregnancy, because obese women may have more complications during pregnancy.
Miscarriage. Because today there was a presentation from one of the companies about their medication, and they recommend its use in PCOS. So I
don't
think this part needs more studies, and waiting for
yes, I think studies are needed to that, RCTs, in order to have draw conclusions on that.
Any more questions or comments? So thank you very much.
Thank you.
With that, we conclude our session. Thank you for the speakers, for your audience, and for our dear, my dear co-chairs. Thank you very much.
Please, please we will begin the session. Welcome to everyone. The first speaker, Professor Ioannis Missinis from Greece, will talk about is there an optimal dose of FSH for ovulation stimulation.
Can I start? Thank you. Thank you, Mr. Chairman, ladies and gentlemen. It is my pleasure to be here. I would like to thank Professor Gamal Serur for inviting me to participate and also to participate as chairman in this session, but also as a speaker in this meeting once more in Cairo. I have no conflicts of interest for this particular talk. Now, before we discuss about ovarian stimulation, it is important, I think, to distinguish from ovulation induction, because there are two different conditions. Ovulation, or two different processes anyway. Ovulation induction means, or at least is applied to anovulatory women, and the aim is monofollicular development and monoovulation, while ovarian stimulation aims at multiple follicular development for in vitro fertilization. And the optimal starting dose in ovulation induction is different than in ovarian stimulation. For example, here in ovulation induction depends on the cause. In WHO group 1, which means hypogonadotropic, hypogonadic women, it is FSH plus LH, because LH is obligatory here, and the usual dose is 150 units, the starting dose, while in WHO group 2, which is mainly women with polycystic ovary syndrome, it is the chronic low dose of FSH, 50 to 75 units as a starting dose in the step-up protocol. Now, in ovarian stimulation, there seems to be a difference between the so-called fresh cycle embryo transfer, or fresh cycle converted to freeze-all because of the high risk for the ovarian hyperstimulation syndrome, and the so-called elective freezing cycle that starts from the beginning with the aim to freeze all embryos. Important also is the degree of expected ovarian response, hyper, normal, or poor responders. So in my talk today, I will discuss separately about the fresh cycle embryo transfer and the elective freezing. As I said, the cycles that aim at freeze-all from the beginning of the cycle. And in terms of the first cycle embryo transfer, we have demonstrated many years ago that there is a positive correlation between the number of the follicles that are selected and the mid-follicular FSH levels during treatment with FSH, which means that the higher the levels of FSH, the greater the number of the follicles that are selected. And this is also reflected in the serum estradiol concentrations, which increase significantly with the FSH levels, and is in fact increasing as long as FSH is maintained high. Now, induction of multiple follicular development, however, means multiple oocytes. And the question is, what would be the relationship between the number of the oocytes and the dose of FSH? Well, according to this large registry from USA that included more than 650,000 cycles, that data were analyzed by the Society for Assisted Reproductive Technology, SART. It was shown that the number of oocytes that are retrieved increases up to a certain dose of FSH, but then as the total dose of FSH increases, there is a significant decrease in the number of those oocytes that are retrieved. The number of oocytes, of course, is important in clinical practice, and this has been shown in this large registry again from HFEA in the UK, in more than 400,000 cycles, where you can see this data analyzed by Sankara and colleagues in London, that the live birth rate increases in proportion to the increase in the number of the eggs that are retrieved, but this is up to a certain number of 15 oocytes, because after that there is a plateau and then there is a significant decrease in the live birth rate. And similar data have been shown also in this study from China with a smaller number of cycles, almost 2,500 cycles, as you can see, and the highest live birth rate was achieved with a number of oocytes that were collected, retrieved between 6 and 15. So that might be an optimal number of oocytes because after the number of 15, and particularly after the number of 18, there is significant increase in the incidence of the ovarian hyperstimulation syndrome, as it has been shown in this study from the Swedish National Quality Registry of Assisted Reproduction, data that were analyzed by the group of Christina Berg in Göteborg. Similar to that is this study from Belgium by Papanikolaou and colleagues, a prospective cohort study that showed that in women with ovarian hyperstimulation syndrome, the number of oocytes that were retrieved were significantly higher than the number that were retrieved in non-obese, in women without ovarian hyperstimulation syndrome. And in fact, you can see that the number is almost double. So there seems to be an optimal number of oocytes in IVF, and there is an upper limit that seems to be the number of 15 oocytes, and there is also a lower limit that is the number of 6 to 8 oocytes. This is derived from the information that I provided to you, but also from mild ovarian stimulation protocols by the group of Bart Fauser, where the exogenous administration of FSH at a low dose limits the number of oocytes to less than 8. So 8 and above up to 15 seems to be rather optimal number. So in clinical practice, we always aim at an optimal outcome, which means the highest possible live birth rate without ovarian hyperstimulation syndrome. And this can be in fact achieved if we have an optimal number of oocytes, which can be obtained with an optimal dose of FSH. But the question is, how can we estimate this optimal dose of FSH? Well, this is a difficult task. There have been different nomograms in the literature. However, one of them, for example, is nomogram by Lamarca and Sankara, where they used the age, the AFC, antral follicle count, and the basal FSH level, and then by drawing lines, they were able to estimate the average dose of FSH that would be considered the best for this particular case. Let's say in this case they found it was 150 units. They tried to validate this protocol later on in a study that they published 3 years later, and what they did is that they calculated, that was a randomized study, so they calculated the dose, the starting dose based on their own nomogram, and also they compared it with a control dose that was based only on the age of the patients. And what they found is that, excuse me, that the percentage of patients with an optimal ovarian response was significantly higher in those who received the dose according to the nomogram than those in the controls. And also there was a lower response in those who the dose was calculated based on their own nomogram, which means that the nomogram may be helpful. Nevertheless, a subsequent study, this is a retrospective analysis of study of data in Korea. This is only 117 first cycles. They calculated a dose that they called proposed based on the Lamarca nomogram, and they compared it with a dose that was calculated empirically. And what they found is that in two groups, if the dose, for instance, was the two doses were the same or similar, they called the group concordant, otherwise they called it discordant. And what they found is that the optimal ovarian response, which was a number of oocytes between 8 and 14, was similar in the two groups. And also the hyporesponse and the hyperresponse, suggesting that the nomogram by Lamarca, in fact, does not provide any advantage over the calculation of the dose empirically. Now the question is, what is the impact of the FSH dose on the live birth rate? We saw that the impact is on the oocytes, that there is a decrease in the number. What about the live birth rate? Here are data again from this SART registry from USA, and you can see that as the daily dose increases, there is significant overall decrease in the live birth rate, and this is regardless of the number of the oocytes that were retrieved. And regarding the total dose of FSH, again, as the total dose of FSH increases, there is significant decrease overall in, again, the live birth rate, again, regardless of the number of the oocytes that were retrieved. It is interesting in this study that there was a range of dosages, as you can see, between 1,000, 1,000, 2,000, that provided the highest live birth rate, which probably can be considered this dose an optimal dose. The question is whether in fact the optimal dose of FSH can be individualized by using various ovarian reserve tests, for example. The answer, according to the Optimist study from Netherlands, is no. This is in hyper-responders. What they did is that they used 150 units dose as standard dose, and then also they compared it with 100 units dose, and they found that there was no difference in the cumulative ongoing pregnancy leading to live birth rate, which means that in fact by reducing the dose the result is not affected in terms of pregnancy or live birth rate, but they found that there was a significant decrease in the ovarian hyperstimulation syndrome with a lower dose, so that there was the mild and moderate ovarian hyperstimulation syndrome significantly lower. And this has been also discussed, or a similar discussion has been provided in this article here by Brockmans. Based on the ovarian reserve tests, in fact, he presented data that he obtained from this Cochrane database systematic review, in which he was co-author. So it was shown here that with the calculation of the ovarian reserve test, there was a significant reduction in the moderate to severe ovarian hyperstimulation syndrome. So it is clear from what we have discussed so far here that there is an optimum, or at least an optimal number of oocytes, probably between 8 and 15. And the optimal dose of FSH appears to be no more than 2,000 units in total, which corresponds to about 100 to 200 units per day, or on average 150 units per day. Now, what about the elective freezing? Excuse me. And I mean cycles that start from the beginning with the aim to freeze all. Well, there seems to be a difference between the so-called fresh embryo transfer cycles and frozen cycles, according to this registry from Sweden that I mentioned before. And in the fresh cycles, this is related to the pattern of live birth rate in relation to the number of retrieved oocytes. In the fresh cycle, there is significant increase in the live birth rate up to number 11. We mentioned before up to number 15 based on the registry from HFEA. So here is about number 11, but after that there is a plateau and then there is a significant decrease. While in the frozen cycles there is a continuous rise in the live birth rate with the increase in the number of those sites up to a number of 25. There is also another difference between the fresh and the frozen cycles in terms of the live birth rate based on the dose of FSH that was used, and in fact in the fresh cycles if the dose was above 2,500, there was a significant increase in the probability of live birth, while this was not shown in the frozen cycles, suggesting that it may be the endometrium that is affected by the high doses of FSH. And in this study, it was interesting that they used simpling embryos that were obtained from the same oocyte retrieval process, and they were transferred into the same uterus. Thank you very much. Thank you. I will. So it is possibly the endometrium that is affected with the high dose of FSH. And this has been also shown in this study here, which again are data from the SART study, analysis of data that were obtained later on, 2014-2015, and they showed that with the increase in the FSH dose in the fresh cycle, there was a decrease in the live birth rate, which was also shown in the frozen cycles, but this was significant only in the fresh cycles. So the high dose of FSH has an impact, negative impact on the live birth rate only in the fresh, not in the frozen cycles, suggesting again that this may be the endometrium that is affected. Nevertheless, if we look at this data that again were obtained a bit later from the SART registry, it was shown that the total dose of FSH can have an impact on the live birth rate in a donor-recipient model and fresh embryo transfer. And in fact, for every 500 units increase in the total dose, there was a 3% decrease in the live birth rate and the clinical pregnancy rate, suggesting that it is not the endometrium, but possibly is the quality of the oocyte that is disturbed. So there are conflicting data in the literature regarding that, and this is supported further by this study in which PGTA was applied in almost 1,000 frozen embryo transfer cycles, and it was shown that when euploid embryos were transferred, the live birth rate was similar regardless of the use of FSH, the dose of FSH. If the dose increased, this did not affect the live birth rate. And also the age did not affect the live birth rate. And the same was shown in relation to the duration of treatment with FSH. So the live birth rate remains the same if euploid embryos are transferred, and therefore this means probably that it is an impact on the quality of the oocyte, mainly related to an increased aneuploidy. However, this has not been confirmed by any data so far. These data here are from the Valencia group and show that there are no chromosomal abnormalities between stimulated and unstimulated cycles, so there is no difference if you give FSH or not giving FSH, the results are more or less the same. So in fact, they also used 46 cycles, or at least 46 donor women that were studied in both the unstimulated and the stimulated cycle, and they used the same also sperm donor, and they found no significant difference in the chromosomal abnormality. So aneuploidy may not be in fact an issue here, and this is also supported by this data from Brazil that showed that the total dose of FSH is not an independent predictor of embryo aneuploidy. So that needs further investigation regarding the impact on the euploidy on the embryos of the high dose of FSH. Nevertheless, despite this debate, recent study here from China has shown that the percentage of the small for gestational age infants increases significantly when the dose of FSH is above 2,500 units. So this is the odds ratio here, either crude or adjusted, and this is statistically significant, of course, suggesting that there may be an impact of the high dose of FSH on the oocyte, epigenetic effects or other effects that cannot be detected with the usual methods. So to conclude, ladies and gentlemen, it seems that there is no consensus regarding an optimal dose of FSH for ovarian stimulation. In fresh cycles, however, the number of eggs retrieved decreases with the total dose of FSH, An optimal number of eggs between 8 and 15 seems to be the appropriate, or at least what we could name optimal, because higher numbers significantly increase the risk of ovarian hyperstimulation syndrome. The live birth rate decreases with increasing daily total dose of FSH, and individualization of the FSH dose does not improve the IVF outcome, but may reduce the risk of the ovarian hyperstimulation syndrome in hyper-responders, for example, women with polycystic ovary syndrome. An optimal FSH dose seems not to exceed 2,000 units in total. In elective freezing cycles, however, the live birth rate increases with increasing number of oocytes, even up to number of 25 oocytes. And unlike fresh cycles, the total dose of FSH does not affect the probability of live birth rate. And the live birth rate from transfer of euploid embryos is not affected by the total dose of FSH. High FSH doses are not associated with embryo aneuploidy. Any detrimental impact of higher FSH doses on oocytes may be due to epigenetic alterations or undetectable changes in oocyte quality and competency, and higher FSH doses increase the risk of small for gestational age singletons after fresh embryo transfer. Of course, more studies are needed. And before I finish, dear colleagues, it's just to show you information regarding European Board and College of Obstetrics and Gynecology, where we organize exams. These are fellowship exams. They have part 1 and part 2. The next part 1 exam will be in May 13th, 2023. Applications are already open. The part 2 exam will be 6 months later. We also are organizing exams with, in collaboration with ESRE. These are subspecialty exams. Again, there are part 1 and part 2. Those who, there are also fellowship exams, European Fellows of Reproductive Medicine. And for those who are interested, can visit the EPCO website, also the ESRE website, for more information. Thank you very much for your attention.
Thank you, Professor Messinis. One comment on the marker normogram. Is it, from your opinion, optimal for individualize the dose?
My opinion. My opinion.
Yes.
Well, I have not used that in clinical practice. Certainly, we use the ovarian reserve test. For example, if you ask me what I do if I have a patient potentially a hyper-responder, like for instance ovarian or polycystic ovary syndrome, and I'm going to do IVF, I start with a low dose, which low dose is based on the syndrome, because the syndrome is at risk for the ovarian hyperstimulation. And if you consider the optimist study, you could start with 150 units, because 150 units will provide the same results with a lower dose, but this will be the live birth rate. But the higher dose, the standard dose, will increase the ovarian hyperstimulation syndrome. So in order to avoid that, what I do is I use lower dose. Unless you go for freeze-all, and in that case, of course, you give GnRH antagonists, as usually in PCOS, and you trigger the final oocyte maturation by using the GnRH agonist, and then you freeze-all. In that case, you avoid the ovarian hyperstimulation syndrome. So the ovarian reserve tests, because the Lamarck nomogram is based on ovarian reserve tests, is based on AFC and AMH, and age, of course, and FSH, but in the ovarian reserve tests are useful, but they cannot be, generalized, I would say. It's only for specific cases, maybe.
Thank you. Any comments?
We published a study in 2017 with the Japanese of 14,000 cycles of natural cycle single embryo transfer. And we interpreted from that what was the intrinsic fertility of the human oocyte at any given age. A huge statistical number, so it was very consistent. And at any particular age, the baby rate per egg was 4 to 5 times higher without any stimulation at all than with controlled ovarian hyperstimulation. And then we compared that also to later just Clomid-only IVF cycles. And of course we got less eggs, but the baby rate per egg was dramatically higher at any given age you wanted to look at the curve. And so it would seem like your end result is negatively impacted by overstimulation per egg at least.
Yeah, well, you mean overstimulation?
Yeah, by higher dose FSH and overstimulation,
Yes.
COH.
Yeah. If you give higher dose of FSH, you will obtain more oocytes, but not certainly much higher than you would expect. I mean, you can increase the number up to a certain level, and then the number will decrease if you increase the dose. So that may have an impact not on the total number of oocytes, because that may be adequate, the total number, for subsequent embryo transfer as well. But probably if you go for fresh embryo transfer, you may have not very good results. And in fact, the live birth rate is also decreased with a very high dose of FSH.
Yep.
So I think we do not need, very high dose of FSH. We need moderate dose. And then, in the past, I remember that we used up to 450 units. Now, this level is never reached. We do not go above 200 or 250. So very high dose is not needed, in fact. Unless you go for freeze-all. In that case, yes, you will obtain, let's say, 30 oocytes. You freeze all of them, and then you go for, multiple embryo transfers in different cycles in the future, and in that case you can calculate the cumulative live birth rate, which may be okay, may be good. So you will have one shot and you will do many embryo transfers.
I agree. In the U.S., many centers are sort of impacted by the drug company reps, and they routinely use 450 to 600 IU of FSH per day. And the results are terrible, but they think by giving more gonadotropin they can get a higher success rate.
Yes, okay.
Thank you. It's a pleasure for me to introduce the next speaker, Professor Hussam Abdurrahim. He is the director of the Obstetric Gynecology at Al-Azhar University, the head of the department, and he is a member of the Egyptian Fertility Institute Society.
Thank you very much, Mr. Chairman, for introducing me, and good evening. I know it's getting late, so I won't be long. Now, my presentation is about the introduction on part of the reprogenetics. I always consider the beauty of creation is that we are all so similar. We have two femurs, two ulnas, one on each side, 5 metatarsals, 2 eyes, yet we are all so different. None of us looks exactly the same. None of us sounds exactly the same. None of us has got the same fingerprints. So we're all very special. And what gives us this special print is basically our DNA. And in the coming few slides, I'll show you 2 Nobel Prize winners, or 3 rather, in 2 occasions. One of those was back in the 1950s, that was James Watson and Francis Crick, who obtained their Nobel Prize because they identified the structure of DNA, although this was criticized for some time, saying that it was not very rightful. But anyway, it was a fact that they received the Nobel Prize for knowing the structure of DNA that gives us this print. Again, I'm sure that you know the guy on the right-hand side. Again, he received a Nobel Prize for IVF. The one on the left side is waiting for the phone call, so it could happen anytime. And he discovered IVF, basically was the father of IVF, and that's why he received the Nobel Prize. So when you combine those 2 Nobel Prizes, what you expect is really a lot. It's tremendous, by every means. So basically when you in the field of reprogenetics now is knowing the genes that are involved in obtaining a good embryo and hence a good baby. The biggest aspect of this basically is known now as testing the baby, pre-implantation genetic testing with embryo biopsy and knowing exactly how healthy or how good this baby is and its potential for implantation and hence producing the baby. However, this is just an only aspect. The other aspect of the other concept is what we call now individualized medicine. One thing of our being unique, of our uniqueness, that we have different acceptances or reactions to different medications. For example, my ideal treatment for a headache could be a paracetamol. Yours could be ibuprofen. His could be aspirin. So they're different. So individualized medicine does have an impact. And this has a great impact actually on IVF as well. Now I'll go back a little bit to physiology. It's basically DNA and all our genetic material is a 4-letter code. Guanine, cytosine, adenine, and thymine. Or in case of RNA, it's uracil rather than thymine. And basically, as you all know, C pairs with G and A pairs with T. It is as simple as a Morse code or as a computer. Computer is just 1 and 0 or 0 and 1. Morse code is a dot or a hyphen. And you combine them, you get different letters, you get all the words in the whole world. So with this code, it is transferred from DNA, from molecules to RNA, which is called transcription, and then from RNA to amino acids, a process called translation. And amino acids are the building blocks for each and every protein, i.e., for every receptor, for the vast majority of hormones, and these are all formed and coded by DNA and RNA. So it is this code that is actually forming the building blocks. Just give you quick examples of coding. For example, the amino acid arginine is coded for by the letters AGA, AGG, CGA. Threonine is ACA, ACC, and so on. Of course, I'm not expecting to remember this. I can't remember them. But what I want to tell you here is just have a look at the very first code on the upper row, left-hand side, arginine, AGA. Serine, just underneath it, is AGC. So just one simple change in one letter, A instead of C, will give rise to a different amino acid and hence a different protein. So what's polymorphism? Well, polymorphism is a better word than a mutation or abnormality because polymorphisms can sometimes be better than what is called normal. Polymorphism just simply means it looks different. It is caused by mutation in a gene that might involve a gene responsible for hormone production or hormone receptor production. And these are hormones, the hormones that we're used to in induction of ovulation are basically FSH and LH, and these are proteins. And the receptors responding for the binding, again, are proteins. Sometimes, quite often as well, actually this mutation involves just one single nucleotide, i.e. one letter, just as I've shown you, A instead of C or G instead of T. It could be inherited from the father or the mother, or it can happen de novo due to whatever insult a baby or an adult can actually get. And this is actually the key to personalized medicine that is actually just in a science in its infancy, but I think it will develop tremendously in the coming decade or two. So can we actually diagnose these mutations? Yes, of course. And pretty easy. They're available. They get cheaper by the day. So every day, diagnosing these mutations is actually getting easier. So what can we diagnose? We can diagnose single nucleotide polymorphism, usually by PCR. We have to actually amplify the codon so that we'll be able to know exactly what's happening there. Or, more extensively, we can know the whole exome or the whole genome. Exome is actually what's responsible, or the things that we know produce a function. Genome is all the genes that whether we know that produce function or do not produce a function. We don't know about them yet. And these are available, and they're actually being tested on a very commercial basis in some countries, especially in the United States. And I heard that they send you a pot, a plastic pot, and excuse me, you send a spit in it, and you got it back to the lab, and they give you your whole exome after a few days. It wasn't very popular because it used to cause a lot of depression to people who knew their exomes or the genomes when they know that they have certain mutations. And I think one of the studies said that on average, any person of us, an average person, would carry 40 different mutations. Some of them could be responsible for diseases and others do not. So in the field of IVF, there have been the SNP, single nucleotide polymerase, discovered for FSH receptor, or the beta subunit of FSH, beta subunit of LH, and what's called LHCG receptor, because basically LH and HCG, they act on exactly the same receptor, so it's now rather called LHCG receptors. So does this have any clinical significance in our practice? Yes, it does. Well, for example, beta FSH gene mutations has a more severe phenotype than mutations in the receptor. And it does sometimes tell us something about occurrence of a disease, and it tells us a lot about the response of ovulation drugs and doses, whether this particular patient respond to that or this drug, and what dose should be used. And again, it could be one of the variables affecting maybe the FSH dose that can be used in different patients. And there started papers to be published on these polymorphisms and what they do. It started back in the early 2000s, for example, impact of follicle-stimulating hormone receptor polymorphism on efficiency in co-treatment with growth hormone. Does it differ according to the genetic material that the woman carries or not? And then, could polymorphism some hormone receptor genes be involved in follicular genesis to help predicting the patient response or not? And I bet you start to recognize the font here, either very high impact papers like fertility and sterility, and it was about follicle-stimulating hormone receptor polymorphism affecting the outcome of ovulation induction in normal gonadotrophic women. And there's a plethora of papers, hundreds, literally hundreds. And of course, we're not expected to know every single gene polymorphism, but some of them are getting actually more known and more famous. I'll give you some examples here. For example, in the receptor, FSH receptor polymorphism. Well, the expression of receptor is determined. There have been some common polymorphisms in the location of number 680. And it's called FSH SER for serine 680 variant. The codon number 680 could code for asparagine or serine. And because we have two chromosomes, one from the father and the mother, therefore the genotype could be NN, asparagine, or asparagine serine, or serine serine. These particular patients, apparently, they require a higher basal FSH levels, although their fertility is comparable to other people who don't have this mutation, who have normal or lower FSH levels. And for a reason or another, they have a longer follicular phase in their normal physiology. Right, again, in the receptor polymorphism, another mutation at the site 307, codon number D7 code for alanine or threonine, similarly AA, AT, or TT. These are two of the most famous polymorphisms that have been discovered frequently in FSH receptor polymorphism. For example, 680 serine was found to be associated with reduced ovarian stimulation outcome in IVF. 680 asparagine, they show low live birth rates. No one has got really more deep than this, but I think the future will carry further studies in this aspect. Right, just a quick reminder of FSH. It is a glycoprotein, so it is a protein, and specifically, it has a beta subunit that is different from its brothers and sisters, the HCG and LH, which carries 111 amino acids. So, the beta subunit of FSH does have sometimes has polymorphisms as well for its coding gene, and specifically, one of the famous ones described as well is the glycine 211 variant that should code for glycine or threonine. And therefore, similarly, we get GG, GT, or TT. So is this polymorphism, or does it carry any clinical significance? Yes, it does. Apparently, the more polymorphism they have, there's higher incidences and severity of PCO. The basal FSH, LH, and basal testosterone are different, and the sensitivity of exogenous FSH that we give for induction of ovulation is also different. So these people will need to treat them differently if we're planning to do induction of ovulation for these patients. LH, again, different And of course, there are hundreds and thousands of these mutations, and they're all put in genetic encyclopedia, and people start, to dig further in them and see what is really common and what is associated with. Right. So beta LH subunit gene mutation is proportional to PCO, and commonly in the males it is proportional or associated with Leydig cell hypoplasia and familial male limited precocious puberty. So for us gynecologists, it could be one of the causal associations with polycystic ovarian disease. So ladies and gentlemen, to sum up, gene polymorphism is more common than we think. An average person carries at least, 40 polymorphisms, if not more. It could explain many flaws in the patient management, where you get a patient and you expect that she responds to a certain treatment, and surprisingly her response is very poor, or much less than you expect, or even much higher than you expect. It is the key to personalized medicine, which is going to have a great impact in the coming few years, maybe decades. And the cost of testing, although it is getting cheaper, but it is still prohibitively expensive to be used routinely for each and every patient. Thank you very much for your attention.
Thank you, Sam, for this lecture. Two comments. First, what about this is applicable in Egypt for do this gene testing, and when we discover it, we increase the dose, this solves the problem, or we need to do gene therapy?
Okay. Now, first, is it doable in Egypt? Yes, it is. Almost all genetic tests can be done in labs in Egypt. They are expensive. Some of them are sent overseas, but they can be done. This is the first thing. The second thing is, what's the significance? Polymorphisms are hundreds of thousands of polymorphisms, if not millions. What we're waiting for now is knowing the significance of these polymorphisms, whether they have any significance or not. Some of the polymorphisms that I mentioned are pretty common, and we're starting to know their significance. For example, changing the FSH dose, using HMG rather than FSH, using recombinant LH rather than HMG. We're starting to build an encyclopedia of the relevance or applicability of these morphisms and what they mean. We're knowing more and more that they are present, they exist, how common they are. We still don't know much about their significance, what should be done for this and that.
Thank you, sir. Any comments?
Okay.
Thank you very much.
Thank you.
We move on.
Thank you.
To the next speaker. The next speaker is Professor Mohammed Imam from the University of Mansoura here in Egypt, and he will speak about spontaneous urinary hyperstimulation syndrome, a neglected disorder, although not very interesting.
أول واحد اشرب. أيوة خليك معاي. اتفضل يا باشا، اتفضل. افتح الوقت. بسم الله الرحمن الرحيم. My talk today is no يا أخي لسه التانية بقى واحدة ايديا انت غلطت. قعدت السلايد التاني بقى اسف اقفل دي خالص. يا اقفل دي خالص. انت فتحت واحدة تانية. انا اسف فتح بس سلايد تاني. شوف حاجة اسمها تاني واحدة ده. اتفضل يا باشا. My talk today is spontaneous ovarian hyperstimulation syndrome. Is it a neglected disorder, and although not uncommon disorder in our locality? The definition of ovarian hyperstimulation syndrome is abnormal exaggerated response of the ovaries to gonadotropin. I stress here on gonadotropin, not HCG, because can be stimulated by other hormone, glycoprotein. May be iatrogenic, which is common due to ovarian stimulation, and spontaneous without ovarian stimulation. This is the definition of spontaneous ovarian hypertension syndrome, and can be classified into two categories, gestational and non-gestational type. The source of evidence of my talk is up to date 10 November 2022, PubMed till 22, and the Mansoura case reports of our experience in this case. The prevalence of spontaneous ovarian hyperplasia syndrome in 1996, Olam, the first reported a case of severe gestational ovarian syndrome spontaneous. After that, the midline search from that time till now about 455 cases only in the literature, which is very rare. The type 1, which is gestational type, can occur in high HCG without exogenous gonadotrophin. That's say in molar pregnancy, multiple pregnancy, and one differential diagnosis of this case, which is hyperreaction leutinalis, which can occur many times without explanation. The hyperreaction leutinalis, it is bilateral multicystic ovaries, usually seen in the third trimester, and occur with preeclampsia, not meet any specific treatment, not need, and usually found incidentally at cesarean section. You can meet this case during cesarean section. And the differential diagnosis of this two types, cecal lutein cyst and leutoma of pregnancy, which should be differentiated from this picture or this photo. One paper had published by Asyut, Dr. Tariq, in 2000 years about hyperreaction leutinalis, which a very important paper about this talk. Non-gestational spontaneous ovarian hypertension syndrome may occur in the following: polycystic ovarian morphology, polycystic ovarian syndrome, morphology only without syndrome, and primary hypothyroidism, and I stress here on primary hypothyroidism, and gonadotrophin adenoma. And the differential diagnosis of this non-gestational spontaneous ovarian syndrome is malignant ovary, which can mimic it in many times and many items. The pathophysiology delineator 2006 classifies these types into three types. Type 1 mutated FSH receptor, like Dr. Hussam in the last talk. FSH receptor can occur this recurrent, can lead to recurrent cases. And type 2 high SHG is the most frequent type, like molar pregnancy or others, and type 3 hypothyroidism. I will stress here on hypothyroidism, which can lead to a picture like ovarian malignancy. Type 1 mutation is the FSH receptor gene, which is very common, and increases sensitivity to HCG. We see here that LH is like HCG in the beta receptor, and it can lead to the overstimulation of HCG receptor. And the type 2 high concentration of HCG, like overstimulation of HCG receptor, molar pregnancy of multiple pregnancy, and this lead to increased production of vascular endothelial growth factor, which starts the cascade of ovarian hypersaturation syndrome. Type 3 hypothyroidism is very, very important because this cross binding of TSH and the FSH receptor, and the high TSH directly cause ovarian hypertension syndrome, direct, and rise in prolactin, and the prolactin lead to increase polycystic ovarian morphology, and the cascade of the spontaneous ovarian syndrome can occur in primary hypothyroidism due to this mechanism. The rationale of my talk, spontaneous ovarian syndrome is a neglected disorder, although increased the frequency of polycystic ovarian syndrome and polycystic morphology in our localities, multiple pregnancy, and hypothyroidism. The majority of gynecologists are minded and aware only of iatrogenic type only because it is more common and serious, and it is a nightmare for fertility clinicians, which are widely spread in our locality now. My objective is to increase the awareness of the clinician regarding picking up of gestational and the non-gestational spontaneous ovarian hyperstimulation syndrome, and how to manage it, and to present Mansoura experience and the case reports about this condition. The gestational ovarian hyperstimulation syndrome lead to impairment of endometrial receptivity, abortions, preeclampsia, placenta compromisation, and the picking up of this type need high index of suspicion because it is occur about 10 to 14 gestational age week. Heterogenic occur earlier than heterogenic ovarian syndrome. We know that the heterogenic occur about 3 to 8 weeks. And the presentation could not be explained by common medical condition. And the presence of associated risk factor, hypothyroidism, polycystic ovarian morphology alone, the syndrome, pituitary adenoma, or high ECG due to any cause. The non-gestational spontaneous ovarian syndrome may be misdiagnosed as advanced ovarian pregnancy. Very important. You can make this condition can mimic the advanced ovarian pregnancy, and the radiologist can mistake you about this condition and may be ended in catastrophic expiratory laparotomy in some times. The picking up of this type, non-gestational ovarian hyperstimulation syndrome, by IOTA and ORADS and CA125 help in the differentiation between ovarian pregnancy and non-gestational ovarian hyperstimulation syndrome spontaneous. The management, the spontaneous ovarian syndrome is self-limiting. If you diagnose this case, it is a self-limiting continuation of pregnancy, proper treatment of hypothyroidism, very important during pregnancy, and differentiate non-gestational type from advanced ovarian pregnancy is very important by IOTA and the ORADS and the CA 125. And you should, after that, categorize the severity into moderate and severe type and do supportive treatment. I stress here on the supportive treatment due to the time hospitalization in severe cases, maintain diuresis by colloid infusion and anticoagulation and ascites drainage. Our Mansoura experience, we during 2022 this year, 2 cases of spontaneous ovarian hyperstimulation syndrome, 1 case type 2 and the other type 3, and 1 case of hyperreaction urinalis. The case number 1 due to high ECG, primary gravida, 26-year-old, pregnant 10 weeks, spontaneous triplet pregnancy without stimulation, and abdominal pain, distension, and dyspnea, sonar, multicystic ovaries, and ascites. A strong suspicion for ovarian hyperstimulation syndrome as the clinical presentation could not be explained by common medical condition and treatment as a moderate case. And case 2, type 3 spontaneous ovarian syndrome, hypothyroidism, very important, primary gravida, 24 years old, 13 weeks pregnancy, hypothyroidism by lab, and the sonar bilateral multicystic ovaries, the maternal ascites. Management, levothyroxine, 150 milligram per day, and regression of this condition, the ovaries after 20 weeks of therapy. At 8 months postpartum, the ultrasound reveals complete regression of this case, and this is a big of this case. Case 3, hyperreaction urinalis, gravida 2, para 1, 21-year-old pregnant of a single pregnancy, 18 weeks, bilateral enlarged cystic ovaries, and cesarean section was done for this case. Enlarged ovary with suspicious appearance. Frozen section revealed multiple benign cecal lutein cysts. 3 months postpartum, the cysts regressed. Our diagnosis is hyperreaction urinalis, and this is like picture of this. If you minded with hyperreaction urinalis, it is very important picture for this condition. My conclusion, Mr. Chairman and my colleague, although the review of literature has reported the rarity of spontaneous ovarian hyperstimulation syndrome, but it should be considered as a not uncommon problem due to lack of awareness, low index of suspicious misdiagnosis, and increased cases of polycystic ovarian syndrome, multiple pregnancy, and hypothyroidism in our locality, and the negligence of registration of case reports, very important item. Many cases cannot be reported by many clinicians. And also gestational spontaneous ovarian hypertension syndrome can be minimized by proper perinatal care for cases of hypothyroidism, polycystic ovarian syndrome, high HCG. Also, I recommend that not rush for diagnosis of ovarian malignancy in cases with primary hypothyroidism, polycystic ovarian syndrome, or polycystic ovarian morphology and pituitary adenoma, except after confirmation by IOTA or RADS and CA 125. My conclusion also, hyperreaction retinales is benign, self-limiting ovarian pathology, which does not need any specific treatment. The misdiagnosis led to unnecessary ovarian cystectomy or oophorectomy by unfamiliar obstetrician during cesarean section. My recommendation, gynecologists should be alert and aware about the proper evaluation and the correct diagnosis of spontaneous ovarian hypertension syndrome for prevention of mismanagement. Thank you very much.
Thank you very much. Thank you very much, Professor Imam, for this interesting lecture. I would say that the cases are, in fact, very important, these cases, and I have never seen any of them. Any questions?
Thank you.
Yes.
Did any patient need any patient was in need for electrolyte like ringer or saline, or they need other than that? No patient need cases?
Very simple, you can start with this. But colloid is the principal use for this thing. Thank you.
Thank you to Muhammad for this talk. One يعني comment برضو دلوقتي احنا الovarian hypertension syndrome usually with pregnancy increasing. Yes. Iatrogenic. In this case, you mentioned that they do expectant management for the case during pregnancy, and it's suppressed. What's the mechanism? Or
if you need, according to it is moderate or severe one, like the iatrogenic, but no interference other than this fluids and treatment ascites.
Yeah, from your experience, the case in Mansoura, it's self-limited, yes?
Moderate time, moderate time. Need fluids and follow up after.
Thank you.
Thank you very much.
There's recorded cases, the obstetrician was obliged to terminate this pregnancy since it was severe one. There is a recorded case of severe hypertension syndrome with pregnancy. And the obstetrician was obliged to terminate this pregnancy.
I differentiate between iatrogenic and symptom. Due to ovarian stimulation, like you were saying. But the symptom was not need any termination because it can be self-limited after that. Thank you.
Thank you.
Thank you.
Next speaker, Professor Tariq Al-Husseini. Professor of Obstetric Gynecology at Asyut University. The topic about letrozole infertility and assisted conception. Welcome.
Let's interview them. أنا عايز أرمي. شفنا ال حضرتك منه ولا hyperaction analysis. It was a case report. It was diagnosed as having bilateral ovarian cysts, multicystic ovaries, big ovaries, and it has been operated upon in the second trimester. But we thought at that time that it is benign, so one ovary was removed. We didn't have the frozen section. And it came back as a hyperaxio lutinalis, and this was a lesson to us and to others that the management is only conservative, doesn't need any treatment, the hyperreaxio lutinalis. The year 2000. And I have seen 2 cases after that. So, ladies and gentlemen, good afternoon, and I first would like to thank the organizing committee for inviting me to this fruitful meeting, and I actually would like to thank you all for your perseverance and waiting up till 6:30 in the late in the afternoon. My talk today is on the letrozole infertility and assisted conception. This is where I come from, Asyut, Upper Egypt. I have no conflict of interest regarding this topic. My objective, the first one would be the short note on the mechanism of action of letrozole. Second, what its use in infertility treatment. Third is the use of letrozole in assisted conception. And finally, upon the safety of letrozole. As we all know, letrozole is a non-steroidal, highly effective oral aromatase inhibitor, which inhibits the conversion of testosterone and androstenedione to estradiol and estrone, both in the ovary and also in the peripheral tissue in the skin. It is not, up till now, approved by the FDA as a treatment of infertility. However, it has been used in many patients, in particular women with PCOS and type 2 and ovulation. As I mentioned, it has its inhibitory effect on aromatase enzyme and results in blockage of the conversion of androgens into estrogens. It is rapidly and completely absorbed from the gastrointestinal tract, and it has short half-life time, not exceeding 2 days. And this is the original medication of letrozole, and as we can see here, it blocks the aromatase enzyme, and therefore it prevents the conversion of androgens to estrogen. The proposed mechanism of action is 2 things. First is central one. It causes the release of pituitary hypothalamic axis from estrogen negative feedback. And the second is intra-ovarian, which block the conversion of androgens to estrogens, and thereby leading to accumulation of androgens inside the ovary, and hence increase the sensitivity of the ovary to respond to stimulation. Because letrozole does not inhibit the negative feedback of estrogen, it usually induces single follicular development, and it avoids multiple stimulation. And again, it has a relatively short half-life, between 41 to 48 hours. Therefore, the estrogen target tissues, such as the endometrium and cervical mucus, are potentially spared adverse effects. Therefore, letrozole has less effect on the endometrial thickness and receptivity, and it also has a more conductive endometrium to embryo implantation. For patients with WHO group 2 anovulation, which is normal, as you all know that WHO group 1 is hypo, group 2 is normal, group 3 is hyperprolactinemia. There is a high quality evidence shows that letrozole is superior to clomiphene citrate in terms of ovulation rate, pregnancy rate, and live birth rate. It did not differ in terms of OHS, multiple pregnancy, and miscarriage rates. And according to the above evidence, the current recommendation is letrozole used as a first line agent for PCOS and other WHO group anovulation patients. This is the latest meta-analysis in 2019. يبقى دلوقتي there is no place for using clomiphene citrate in PCO. First line is letrozole, and you can use clomiphene citrate if the letrozole is contraindicated or it is associated with any side effects. The diagnosis of unexplained infertility is after intensive evaluation of both male and the female. We cannot find a cause. And in this issue, I'd like to draw your attention that it does not recommend a laparoscopy, i.e. if you do have a quite normal hysterosalpingogram, this is sufficient to exclude tubal factor, and you don't need to do a laparoscopy to confirm that this is unexplained infertility. Unexplained infertility affects 10 to 30% of couples seeking fertility. A systematic review and meta-analysis in 2019, 3 years ago, showed no difference in terms of clinical pregnancy rate, live birth rate, spontaneous miscarriage, or multiple pregnancy rate. Letrozole would achieve monofollicular development in most cycles, thereby reduces multiple gestation with a comparable pregnancy success with gonadotrophins. So it might become the first choice again for treatment of for unexplained infertility. However, more studies and more randomized control studies and more evidence is needed. Mechanistically, letrozole administration in the early follicular phase will result during ovarian hyperstimulation, will increase the androgen inside the ovary and therefore increase the responsiveness of the ovary to gonadotrophins. For poor responders, some preliminary reports show that potential beneficial effect of letrozole improving ovarian response, i.e. increasing the number of eggs to FSH and reducing the number of gonadotrophins. However, this has been not translated in improving the pregnancy rate. On the other hand, for normal and high responders, co-treatment with letrozole significantly lower gonadotrophin consumption and reduce the incidence of OHSS without affecting the outcome of other groups with a similar or higher birth rates like other groups. Adjunctive use of letrozole may also be an effective means of low-cost IVF and ICSI cycles in developing countries like ourselves now in Egypt when there is a shortage of the medication. And I'd like to make here a warning or an advice to the society to have a look on the shortage and very high pricing of the medication at that moment. OHSS is a potentially life-threatening complication of ovarian stimulation during ART cycles, and it has been shown that letrozole has a prospective randomized controlled trial 3 years ago showed that PCOS patients with extremely high anti-Mullerian hormone co-administration of letrozole will result in the incidence of OHS. Unfortunately, the effectiveness and the mechanisms by which letrozole work in reducing the OHS is lacking. However, this is most probably through reducing the vascular endothelial growth factor. And we need more randomized controlled trials in this term. For the key to success in frozen embryo transfer is the preparation of the endometrium to be receptive of the embryos with synchronization of the endometrium and the embryo development. Some studies showed that letrozole is superior than natural HRT therapy in clinical pregnancy, live birth rate, and miscarriage. However, the latest Cochrane systematic review failed to show any evidence of any benefit of any of the protocols used, whether the natural HRT or letrozole. So all of them do have equal efficacy. What about the use of letrozole in treatment of endometriosis associated infertility? Current evidence is lacking and is limited. And why we can use it? Because it can suppress the locally produced E2 by endometriotic deposits. And the other impact that it improves or increases ovulation. The efficiency of letrozole probably varies from different stages of endometriosis, and more trials are needed to have an evidence and guide when and how to use letrozole for infertility-associated endometriosis. What about fertility preservation? Compared with the standard controlled ovarian stimulation regimens, letrozole combined with FSH significantly decreased plasma E2 peak concentration. And this might be very important in those hormone-sensitive cancer. And on the other hand, its addition or inclusion in the controlled ovarian stimulation had the addition of letrozole did not have any negative effect on the number of mature oocytes collected or on other efficacy endpoints. This is from our unit in Asyut, Egypt, when we used high dose in letrozole in women with one blocked tube. This rationale, or the rationale of the study, is that superovulation with high dose letrozole might ensure follicular growth from both ovaries, including the one which is related to the patent tube as well as the blocked tube. Letrozole in a dose of 10 milligrams per day, i.e. 4 tablets, was chosen to avoid the anti-estrogenic effect of clomiphene citrate on both the endometrium and cervical mucus. What about safety? In the past, in more than 10 years ago, there was a concern about the use of letrozole for ovarian induction because it might be associated with teratogenic effects. However, subsequent published high-quality researches demonstrated that the rate of overall chromosomal abnormalities, congenital malformations, perinatal outcome, and pregnancy outcome was not higher in the letrozole group than in the clomiphene citrate group or the general population. Further studies are needed to determine the optimal dosing, especially if you are going to use the large doses for longer periods of time. Long-term safety for women and children born to whom patients received letrozole. So, Mr. Chairman, I'd like to conclude that aromatase inhibitors are now comprise a new type of ovulation-inducing drug. The application is not only limited to the clinical treatment of ovarian induction for timed intercourse, but have many aspects in infertility treatment. Besides, letrozole is more accessible, has fewer side effects, and lower cost. It is much cheaper than gonadotrophins. Its superiority for ovulation induction in WHO group 2 and ovulation patient has been confirmed by high quality clinical basic studies. And finally, I'd like to thank you and wish you all a nice stay in our city. Thank you very much.
Thank you, Dr. Tarek. One comment on letrozole and clomiphene citrate. I think the key point in the difference in the clomiphene citrate is its long duration of action, while letrozole is short, because both is anti-estrogenic. But letrozole is aromatase inhibitor for short half-life. Is it true?
It has a shorter lifetime, yes,
Yes.
but it's not anti-estrogenic. It
Aromatase
has two
inhibitor.
mechanisms of action.
Yes.
The first one, in the ovary, it prevents the conversion of androgen to estrogens. So the androgen in the ovary increase, and this improves the response of the ovary to the gonadotrophins. The second thing that it seems that letrozole result in lowering the peripheral estrogens, both estrone and estradiol, and this stimulates the hypothalamus and anterior pituitary to produce FSH, and this is result in physiologic ovulation, and this is in most cases, if you are going to give the one pill or two pills, i.e. 2.5 or 5 milligrams, it will result in single follicular growth.
But if we continue to empirically, if we continue imagination, we continue the dose of letrozole for 10 days, the FSH was coming from the pituitary will pass to the ovary, and the aromatase enzyme is not active. There is no estrogen. FSH from the ovary, from the pituitary, will go to the ovary, and
the recommended dosage and duration of treatment for letrozole is for 5 days.
Yes.
Yeah, this in exceptional cases. What would you benefit from increasing the duration of treatment?
it's not benefit. I think it's
You can add after the 5 days if you don't reach the desired follicular growth. You can add gonadotrophins at that time. When the follicle reaches 12 to 15 millimeters, you can add gonadotrophins. But I don't think that there's any need to prolong the duration of it.
Well, thank you for the nice presentation. Just wanted to mention that letrozole is off-label for infertility treatment. This is very important to explain to the patients. The reason is that probably increases, well, as it has been said, the teratogenic effects. But because this has not been withdrawn from the company that produces it, it is still off-label.
Yes, it's in the USA.
We should inform the patients about that.
It is in the USA off-label. I mentioned that.
Yeah, yes, but just wanted to mention that again. Yes.
Yes. Is it in Europe also? Is it not approved?
Nowhere.
Nowhere.
Nowhere. But it's been used. We have to explain the patients the possibility of increasing the teratogenite anyway. Let's say.
Yes. Even after the.
I mean, if the EPCOC, the ESTRE guidelines also mention that. Although they say also that clomiphene has not been approved, but clomiphene has been used since 50s or 60s, something like that. But for letrozole, it is the company that produces it that considered it off-label for infertility treatment.
Thank you. Any other questions?
Yes, I'm fully agree with you that the letrozole can make iatrogenic cardiac problems and this is mentioned by in Canada.
Yes,
They start the
Casper.
letrozole, the
Casper, 10
septal
years ago.
defect, and like that. I would like to ask a question about the why you didn't raise the dose of letrozole in cases of hyperresponders or weak ovulatory. Why in the single blocked tube?
You mean in our study?
Yes, in your
Yes. In our study,
experience.
the rationale was that ovulation, if it occurs from the blocked site, very rarely it results in pregnancy from the other side, the wandering egg. So we increased the dose in order to ensure ovulation from both sides, because you can't direct the ovulation from the patent site, the patent site. So increase the dose. Those patients were infertile after ectopic pregnancy, removal of the tube for about 2 to 3 years. So they waited for the wandering and for pregnancy from the site which is related to the patent tube. So increase the dose to ensure that it is from both sides. And we followed them up to know exactly that the ovulation came from either the patent site or from both sides or from one side only.
Thank you.
Thank you very much. It's a pleasure for me to introduce Dr. Muhammad Walauddin, Professor of Obstetrics of OBGYN, Alexandria University. He will address us about anti-Mullerian hormone, a great gift enveloped by many disputing issues.
Thank you, Mr. Chairman, Co-Chairman, dear colleagues, good afternoon. First, I would like to thank Professor Surur and the organizing committee for this kind invitation. And I know that it's the end of the day. I'm trying to rush in my presentation as fast as possible. No potential conflict in interest report. AMH is one of the very common and important tests in compared to other tests in evaluating the ovarian reserve. Sorry. As we all know, AMH is produced by granular cells of small growing follicles in the ovary. It is non-hormonal dependent and less sensitive to intercycle variability, and serum AMH level is strongly correlated with the number of growing follicles, so it is a very good marker to evaluate the ovarian reserve. And to make a clear distinction between pool of resting primordial follicle and the pool of growing follicle, the term functional ovarian reserve 4 has been suggested, and it seems to be more accurate in compared the ovarian reserve. Functional ovarian reserve constitute of small follicles, 2 to 5 millimeter in diameter, from which one follicle then distended and under the effect of SH going to ovulate. We can see here the pool of growing follicles is known as the AMH producing follicles, and thus serum AMH levels directly reflect the functional ovarian reserve. However, AMH measurement is not a carte blanche. It has surrounded by many limitations, and the major limitation concerning its assay. And due to lack of international reference range for its immunoassay, and the difference up to 20% has been reported in different immunoassays. On the other hand, storage of the sample may negatively affect its accuracy. In females, AMH starts in the 36 weeks of gestation, reach the peak at 25 years, and before declining to the undetectable values near the menopause. And here we can see the declining follicle pool starting from 5 million till around 1,000 near the age of menopause. As AMH is highly correlated with intrafollicle count, it is considered to be best marker for hypo and hyper responses. Actually, for the hyper response, it can protect us and our patient from ovarian hyperstimulation syndrome. And regarding to the hypo response, AMH level may be the best marker for ovarian aging and menopausal transition. Based on recent current studies, the prediction of value of AMH for the age of menopause still remains controversial, and just to have a comparison with these studies is difficult because they have analyzed different age ranges, duration of follow-up, and the AMH assays. And due to the clinical importance of AMH, it has led to development of several AMH assays. We had here the manual assay, the modified Gen2 assay, instead of old DSL and IPC old assays. And we also have another assays, the ELISA and the PICO AMH assay, using different antibodies than the Gen2 AMH assay. Recently, we have two automated immunoassay. One came from Beckerman and other from Roche. And these automated assays seem to be more sensitive and more accurate than the manual one, as it increased the assay precision, reproducibility, and speed of measurement. What is about the factors affecting the AMH level? Actually, we know that AMH level is 2 to 3-fold higher among the PCOs. This is very common. On the other hand, a history of surgical ovarian surgery may decline the AMH and ovarian reserve. And we heard today in the morning from Professor Kennedy that the AMH level will going to be affected after ovarian surgery, whatever the skill of the surgeon. And many centers advise to evaluate the AMH before and after surgical intervention. 6 weeks after intervention, no, we have to do another one 6 months, because you may have increased in the AMH. Chemotherapy that definitely affect the AMH level. Oral contraceptive users, obesity, and finally vitamin D deficiency. So, Mr. Chairman, before I start my conclusion, I would like to raise a point, and this is a very important point or question. Why we do all these tests for regularly menstruating women? Why we depend on the AMH report, whatever the lab repetition is? Sometimes we face with a patient with 0.5 nanogram per meter, 0.4, 0.1. And with simple ovarian induction by chromophene citrate, we are going to have 2 or 3 follicles, nice endometrium, good mid-luteal progesterone, and some of them became pregnant. So don't depend only on the lab report. You have to trust your ultrasound, as Professor Human Fatimi said 3 weeks ago. Don't do any MH if it's not needed. It's not a routine. So, Mr. Chairman, in conclusion, AMH between method variability can be ascribed to various processes in the analytical phase of testing. The most significant contributor is the lack of international standardized material to ensure uniform calibration. Other factors that influence inter-assay variation include antibody design with variable specificity, incomplete knowledge about which isoform to measure, and method of vulnerability to analytical interferences. And finally, over the last years, the number of assays for AMH measurement has increased. However, differences exist between assays, and an international standard for AMH is therefore urgently needed to establish assay-dependent cutoff values. And thanks for your attention.
Really, the storage is not the only detrimental effect of the result. Also, the transportation.
Yes, left to left, I mentioned.
عشان to do that, you must send your sample immediately either to the central. يعني عندنا مش عايز اعمل دعايه يعني معمل البرج اللي في القاهره، يعني لو انا وديته معمل البرج في اللوكاليتيز وهم بيعملوا ريفيرال مع الريفيرال بتاعه والترانسبورتيشن I observed that the result is completely different than my expectation with the anti-critical count.
I fully agree with you.
So I feel that in Egypt, most obstetricians and gynecologists have ultrasonography in his center. So while we shift to antenatal hormone, he has عنده and he is working. وبعدين usually it's included with the exam. يعني the expense is more or less nil, nothing. So I feel that antenatal hormone is very rarely used except if the patient too obese to be detected by ultrasonography or there is no equipment in the center, reliable one.
The problem, sir, is when the physician or clinician just see the report of the patient with very low AMH or low AMH, just he said to the patient, there is no way. So the patient come mad. Why? You have your ultrasound to see your arterial follicles. You have many tests, another test that I start with. And don't depend on the AMH. Don't.
For the last 10 years, I don't send sample for antenatal hormone except just one per year.
Oh, my God.
Thank you, Dr. Muhammad, for this talk. I think I agree with you that AMH is nowadays is decline. I think all over the world, the anterior follicle count is more beneficial and more practical. And for these points and the limitation, yes, it's not used routine in Egypt and even outside Egypt.
I think it's still a useful test, although there are problems with the methodology, as you mentioned, and correlates well with the AFC.
Yeah.
So we can use AFC in clinical practice if we are familiar with the way to do that, and without using AMH. It's not necessary. It's easy to do an ultrasound scan and measure the small follicles, small antral follicles. That, as you mentioned, are about 3 to 5 millimeters, according to Guzon. And I think, yes, the antral follicle count is equally good with the AMH.
Yeah.
There is a question there.
ثانك يو دكتور ولاء بيه على المحاضره الجميله. الاي ام اتش احنا بناخده لما نيجي نقيم الحاله بناخده كجزء من تقييم حاجات تانية كتير، واحنا بنعمل كاونسلنج فور بروجنوزس اوف ذيس كيس. يعني اي ام اتش انترال فولكل كاونت، اف اس اتش، البريفيوس ريكارنسي اوف اكزي، الاي اف سي دي مهمه جدا. فهو واحد من ضمن حاجات احنا لازم بنستخدمه لو عملنا حاله حقن وما حللناهوش، رغم البروبلمز اللي موجوده في الميثودولوجي بتاعتنا في الريف بالذات في المحافظات اللي هي غير القاهره واسكندريه، بيبقى في بروبلم فعلا في النتائج. لكن احنا بنجمع مجموعه حاجات ونعمل يعني كاونسلنج للحاله بناء على الحاجات الكتير دي. يعني لو الاي ام اتش مثلا 3 من 10 او 4 من 10 والاف اس اتش تحت ال8 تبقى حاله فيري جود، هتطلع 2 او 3 او 4 كمان فوليكلز ميبي. لكن السؤال المهم، انت حضرتك قلت ان هو الاي ام اتش نوت سنسيتيف تو ذا سايكليك هرمونال بتاع البيريود. ليه سنسيتيف؟ اذا هو سنسيتيف مش نوت سنسيتيف. فهل في
The
sensitivity
intercycle variability. It is
للانترسايكل
more or less
هرمونال
stable.
variability؟
You can do it in any
احنا قلنا
time.
ليه sensitive حضرتك؟ اذا هو فيه sensitivity؟ هل في حاجه حديثه
Less
بتقول ان هو ممكن يبقى سنسيتيف؟ ونسال ممكن يبقى سنسيتيف للسايكليك، لان كان فيه بيبرز طلعت قالت ان هو سنسيتيف للبيريود زي الاف اس اتش والال اتش، وان احنا المفروض نحلله قبل البيريود مباشره بيومين ثلاثه، مش بعد، مش في الفوليكولار البروليفريتيف فيز. فهل
No, I'm not agree with that because, as I said, I would like to explain my colleague. He would like to do it. Okay, the AMH at any day of the cycle, yes, you can do it at any day of the cycle. I didn't mind that you do AMH, but don't depend on it alone.
Okay.
Don't do it for routine work. This is number two. As Professor Sherbini said, I did it very little, for very low number of patients, if I be suspicious, and that's it.
not depend on it alone يعني.
Yes.
Any question?
شكرا.
Thank you, Professor Wala, for your nice presentation. I just want to ask you, low MH, or I'd like to stress on this point, low MH does not mean that this is an indication of a conception. Low MH means that there is a decrease in ovarian reserve. However, many patients with low MH get pregnant spontaneously.
That's what I've mentioned.
Yes, and this is very important in counseling because all of us now see young age women with low ovarian reserve. And some women go and rush because they are being told that you need an ICSI or IVF and your chances are limited. However, they get pregnant one or 2 months thereafter spontaneously. So I'd like you to know your opinion about this and to stress that low ovarian reserve does not mean IVF. Low ovarian reserve means that the ovarian reserve is low, and if we are going to do assisted conception, we're not going to get very many eggs.
Thank you. Thank you very much.
Any question?
Okay.
طب الأول في سؤال للدكتور محمد ولاء قبل ما طب اتكلم بس دكتور محمد بعد
اتفضل.
Thank you, our Professor Dr. Muhammad Wala, for this very nice lecture. And my question, according to this knowledge, we should not depend on anti-Mullerian hormone at all. Otherwise, if we see anti-follicular count,
Antifollicle count. Antifollicle.
أيوة.
Yes.
يعني أنا لو عملت لو أنا شفت الانترافوليكال كاونت بسيط ولو بسيط ما اعملش ولا اعتمد على الانتي موليرين هرمون.
Listen, when you found a very low number of antifollicles, say 2 or 3 in each ovary, say. So
in one ovary.
Okay. So if you try to do a simple induction of ovulation with chlorpheniramine, with letrozole, whatever, just see what had happened.
Yes.
This is called a test for ovulation, and I explain this to my patient. I will going to test. I'm not going to treat. I'm not going to treat. I'm going to test your ovulation by very simple measures. No gonadotrophin, nothing. So if I had 2 follicles or 1 follicle or 2 or 3 follicles, and then see the endometrium, and then doing the mid-luteal progesterone just to prove it. This is okay. As Professor Tariq said.
Yes.
The low MH, even or low number of antral follicles, not means that the patient will she's infertile and need IVF or something like this. Simple ovulation. We started gradually, but we don't depend on MH rushing as routine. And you know quite well, in Egypt, they do in some centers as routine. And
Yes.
this is my mission.
I have a patient, 40 years old, gravid para 3+1, and have adenomyosis and very low anti-Mullerian hormone, and have only 2 follicles, and this patient become pregnant. And this patient become pregnant.
Maybe.
What's your
Yes.
opinion?
Okay.
And this is a rule or not?
No, it's not a rule.
AMH
It's not a rule.
does not predict the pregnancy. It predicts the ovarian response only. If the patient will respond or not. Therefore, even with 1 follicle, the patient can become pregnant.
Thank you.
Thank you.
The importance of low ovarian reserve is to give impression to the patient not to postpone the marriage and the ULI, or not to postpone the pregnancy.
Because Dr. Mrs.
As far as the time will affect the ovarian reserve. Especially في الجيرلز اللي هم مخطوبين تقول لك بنقعد 4-5 سنين 4 to 5 years لغايه لما تجهز كل البيت full formation need. يعني جت لي واحده عندها 40 سنه وبعدين بتقول لي انا فضلت مخطوبه 7 سنين لغايه she is 40 years old and she was fiancée at since 7 years and she is waiting to have complete building and the complete furniture of her home and she has just 1 antral follicle here and 1 there and she failed to get pregnant neither by natural pregnancy nor by assisted reproduction. So the message for those one, either they are coming with amenorrhea as a girl or they are coming for infertility as a lady, that is the proper message for her. It's a matter of counseling to prevent the problem of low ovarian reserve. Thank you.
Thank you, sir.
Muhammad.
Professor Mrs. يعني the difference between ovarian induction of ovulation and ovarian stimulation. You mentioned that it is for 1 follicle and the other for multiple follicles. The induction of ovulation only for an ovulatory cycle, but ovarian stimulation can be done for 2 cycles, ovulatory and non-ovulatory. And ovarian stimulation also can be done, another term, super ovulation. We should differentiate between super ovulation and controlled ovarian stimulation. Super ovulation is a type of ovarian stimulation to induce few follicles for IUI or others, but controlled ovarian stimulation for IVF or EGSI. So the difference not only the number of follicles, but it is the first for an ovulatory cycle, but the second can be done for the 2 cycles, ovulatory and ovulatory. Just a comment on your opinion.
For ovulation induction means that anovulation is the reason for infertility. And the reason for infertility means that there is no follicle. So we have to induce 1 follicle. That's why we aim at monoovulation for ovulation induction. For ovarian stimulation, we aim at more follicles because we need to have more embryos for transfer, either breast.
Ovulation and controlled ovarian stimulation.
Yes, there are 2 different things anyway. There are 2 different, because in the papers you may read in good journals, ovulation induction, they mean ovarian stimulation. They are 2 different things.
Thank you. This is the end of the session now. Tomorrow the session will be at 8:30 at Hall 1. Thank you.